summarize it and say we are happy to have you, Mary Beth, very well known in the field of HIV, having sat and written a lot of our guidelines in this country. Dr. Mary Beth, you're most welcome to come and present on advanced HIV disease.
Thank you so much, Prof. Sika, for that kind introduction. Thank you, KAP, for this invitation to come and make this presentation. So I'll be talking today about advanced HIV disease care in Kenya, a status update, and a call to action. So as I start, I know the room is not full, so I was hoping this would be very, a bit interactive, but I just wanted to ask a few questions at the beginning. So how many of us work in public health facilities, either county or national teaching and referral hospitals, just by show of hand? How many of us are comfortable managing patients with malaria, by show of hands? Okay, how many of us are comfortable managing patients with hypertension? How many of us are comfortable managing patients with HIV? Oh, the numbers are still constant. So my last question is, how many of us, when they reach a patient with HIV, have a morbid fear and all they can think of is consult CCC? Oh, that's really nice and very honest, because that's what I'm hoping to change today through my talk, just to see how we, as physicians, need to embrace the care of HIV patients. So I've prepared a fairly short presentation, and this is the outline of my presentation. And I'll probably repeat this poll again towards the end when the room is more full. So we look at what is advanced HIV disease, advanced HIV care in Kenya, the status update, newer products that we will be receiving in the pipeline, and then the role of the physician in AHD care, and conclusion. So this presentation, I made a presentation like this last year when we were in Kisumu, and this is just a follow-up of that presentation to show us where we are, because I had a slide that was showing where we should be going, and I'll be providing that update where we are. So this is a publication that was came out in New England Journal of Medicine in February 8th, and it was really a plea from some of the people really at the forefront of advanced HIV care. Nathan Ford is from WHO, and Joe Jarvis has done a lot of work around cryptococcal meningitis. He's from London, but he's based in Botswana. So they wrote this sort of proposing that advanced HIV disease should actually be considered as a neglected disease because it remains under-resourced, and therefore we don't have a lot of resources to support the patients who need the most care. So this slide, I still had it last year, just to refocus us. When we look at advanced HIV disease, we have a definition, and I want us to focus on the definition that's for adults. So in adults, adolescents, and children who are older than 5 years, advanced HIV disease is defined as having a CD4 count that is very low, less than 200 cells per millimeter cubed, or a patient who presents with WHO clinical stage 3 and stage 4 illnesses, and I'll show you what are these illnesses. And then we look for advanced HIV disease in patients who present to care, so patients who come and tell us they are newly diagnosed or come to the ward setting, or those who are returning to care after treatment interruption, and those on ART who are experiencing treatment failure. Our biggest contributor now to advanced HIV disease is actually a lot of our clients who are returning to care after treatment interruption, and this is not a provider interruption. The client just fails to engage or drops off care because now we are doing test and treat. So sometimes our patients are not ready for treatment, but we make them take the treatment and they fall out of care. So for those of us who are older in this room, Dr. Yosa, Prof. Sika, who really practiced HIV even before the advent of ARVs, these are the patients who actually have AIDS. So this is a renaming of what we already had before, but it's because over the years we focused on viral load as a tool to monitor treatment, and therefore we've neglected a lot of the patients who are likely to die, and therefore this renaming of advanced HIV disease was just to refocus attention to the people who need all of this. I showed this slide again last year to show us the commonest causes of death in patients who are hospitalized with advanced HIV disease or AIDS. And the commonest cause of death, or the leading cause of death, still remains tuberculosis, followed by cryptococcal meningitis, and these other opportunistic infections, including toxoplasmosis, pneumocystis, jirovecii pneumonia, and severe bacterial infection. So when we have these very sick patients in the ward, we should be looking out for these opportunistic infections. These are the sickest patients in the ward. The clinical officers who run our CCCs are trained to serve patients who are well, who are ambulatory, who are fairly stable, and can go home. So when we're in the ward round and we ask them to come and see the sickest patients, we actually are putting them in a difficult position because they are not really trained to care for these very sick patients. Most of them, they know how to manage patients who are stable and in the outpatient care. And that's why in this room, I know we are physicians, we have physicians in training. We perhaps even have some medical officers who are attending these sessions. Because these patients come to the ward, we really have to regain our place in taking care of these patients without necessarily resorting to calling the CCC staff, who will be very sort of disadvantaged in looking after the patients. So where are we in terms of advanced HIV disease care in Kenya? So I had this slide last year. They were just aspirations, and I'll just be providing updates of where we have reached so far. So because we require CD4 to identify, remember the two definitions. First definition relied on CD4 testing. Second definition relied on WHO staging. And WHO staging underestimates the number of patients who have advanced HIV disease. So CD4 testing is a more reliable and objective measure to identify these patients. So therefore, we require reliable access to CD4 testing and opportunistic diagnostics. And this is really bundled up together. So currently, the NASCO program provides commodities for CD4 testing. And in the same setting, it's almost like a kit, where within the CD4 testing requirements, they'll also provide the TB LAM for diagnosis of TB, as well as even the cryptococcal antigen testing. So these are bundled together because one of the requirements is that for clients who test and have a low CD4 count, they should actually get a reflex cryptococcal antigen screening on the same sample to identify if they have a positive serum CRAG. And then the clinician then would be required to send a urine sample to the lab to assess for the urine LAM. It's considered a point of care test. It can be done in the bedside, but I think the laboratory team, and because of commodities, they actually run it in the lab. So we need reliable access to CD4 testing. We also need to map screening, prophylaxis, and treatment services based on levels of care and define what are called hubs and spoke model, where the hubs are really centers of excellence, where you can have the more serious conditions managed, but then any other facility then become a spoke, and there is a proper referral mechanism to link the two together. So we are currently, through the national program, this is currently in place to identify where the hubs, and therefore focus a lot of resources, even distribute some of these commodities like the newer products will be mainly based at the hubs, but to also map out a referral mechanism where patients can access these facilities within the minimum time possible. So many of the county referral hospitals are really envisioned to be hubs, as well as even some of the sub-county referral hospitals, and definitely the high-level national facilities will be considered as hubs. So there's already an assessment and a tool that's being sent to counties to identify their hubs and spoke. So I put this map here just to help us see the distribution of CD4 testing, because we said CD4 testing is an important tool to identify AHD. And we can see, I think from this map mirrors, I think, a lot of other healthcare distribution services. We have like two parts of the country. We have the resource, like the part of the country that has a lot of resources, and then the rest of the part of the country. But we have a good referral system and networking for services so that any patient who needs a CD4 testing can actually be able to access. So the purpose of this was really to identify the different platforms, because even at the global space, some manufacturers are discontinuing some platforms because there has been a lot of focus on point of care diagnostics, particularly even for CD4 testing, where we have qualitative testing. We have a test kit that's point of care that can just tell you, is the CD4 count less than 200 or is the CD4 count more than 200, and that's important for decision making. But it may still be suboptimal for certain patient populations, like the pediatric population, where you need an absolute number of CD4 count for that decision making. But this is just a general site. This process has been ongoing and is still ongoing because some equipment is being withdrawn or decommissioned, and therefore this map is likely to change. But it just gives us a good baseline, because we said all the commodities are linked. Where you have the CD4 count is likely to also have the TB LAM test, as well as even the cryptococcal antigen commodities. So this other component is establishing AHD treatment centers of excellence for complex, critically unwell patients, such as those with cryptococcal meningitis. And the focus now is identifying the hubs so that these hubs can be developed. And there's a checklist that has been developed to identify the hubs. And because many of you as physicians, even the ExaCop training program requires a certain level of expertise, I'm talking really to the right audience, because the physicians need to support taking care of these complex, critically unwell patients. And this will be facilitated through trainings and capacity building initiatives. I know we have other societies. We have the Infectious Disease Society. We also have the HIV Clinician Society. But a lot of the times, even when we have the conferences, we don't have a very captive audience of physicians as we are having here. And that's why we have to have this discussion with the physician as specialists, as well as even the pediatrician. This same conversation is also taking place with the pediatricians, because it's the same trend. When we reach HIV patients on the ward rounds, we just want to call the CCC team, and we don't want to proceed beyond there. So we are trying to really see how can we harness the existing resources. How can we make everyone comfortable? In just the same way we are able to treat conditions like hypertension, we're able to treat asthma, we're able to treat malaria, we can actually be able to take care of our sickest HIV patients without saying, for hypertension, consult the cardiologist, or for asthma, consult the chest physicians. Because in many of our facilities, even when you are general physicians or even when you're specialized, you still have to see the complete set of different patients beyond even your area of specialization. And then securing reliable access to opportunistic infection treatment commodities, including newer and safer products. So this is what I was talking about, the hub and spoke model for HIV care and treatment. So when we talk of the hub, this is really that high-level hospital facility where the comprehensive advanced HIV clinical care can be undertaken for that critically unwell patient who's about to die. And our role is really to avert that mortality. So we require clinical expertise in management of these critically unwell admitted patients. So we are still in discussion. We had a meeting last week to sensitize counties about the hub and spoke model. And one of the concerns they raised is that in certain counties, they don't even have physicians. We had put one of the thresholds that you must have a physician to be the lead in that facility that you are proposing to be a hub. And they said in some facilities, the highest level of expertise they have is a medical officer. So that discussion is still ongoing. Who will be best placed to be the lead in the hubs? But for all of us who are here, if we come from county facilities, because this is something that is going to happen, then we have to be ready to accept this responsibility, especially if you are a physician, so that you take leadership when there are trainings that are being held to really simplify this concept of AHD, how to manage these conditions like cryptococcal meningitis and TB meningitis and other serious opportunistic infections. We can be part of that discussion. Lab capacity, again, is very, very important. We require lab capacity to be able to monitor the patients we are going to be putting on this treatment. So I'm talking as though this is something new, but it's already ongoing. But what we are saying is that as we rethink and revisualize or revitalize AHD care, we are really trying to put in place systems that can support the care of these patients. So hubs will serve as referral sites for spokes and will manage patients who need hospitalization and regular monitoring. And what is envisioned is that we will have a central hub and several other facilities then become spokes. And there'll be communication between the hub and spoke, so that once you stabilize the patient, once the patient is ready for discharge, you can actually send them to the spoke for continued care, because we know for certain conditions like cryptococcal meningitis, we treat them for a prolonged period of time, up to 10 to 12 weeks, and therefore that communication can be between the two hubs and spoke. So this is just a package of care for hospitalized patients, and this is what the hub should be able to do: perform certain tests, and this is the minimum, be able to offer prophylactics and preemptive treatment, and this is the minimum, and then have the right clinical expertise. And the bare minimum threshold is that they should be able to manage patients who are critically unwell and admitted with cryptococcal meningitis, as well as conditions like tuberculosis, meningitis, which are the more serious opportunistic infections, and then other opportunistic infections like KS, PCP, and bacterial sepsis, and also guide on appropriate ART initiation. And then support adherence, counseling, and home visits to support this component. I'm being shown 5 minutes. So talking about the newer induction regimen, and this is really very important because Kenya will be launching new regimens in conformity with the 2022 WHO guidelines. So in 2022 guidelines, there was a change in the preferred induction regimen for cryptococcal meningitis, and what is now preferred is a single high dose on day 1 of liposomal amphotericin B combined with 14 days of flucytosine and fluconazole in those particular doses. And Kenya has adapted this regimen, and will be, these regimens will actually be available in country from July 2024. Some of you in the private sector may already have some of these regimens, but in the public sector, where many of our patients attend, we will be having this regimen from July of 2024. So part of this sensitization and training really needs to happen between now and July, when these regimens are available and will be supported by the partners that currently support HIV treatment. So in the interim period, we've developed this guideline that gives 5 options, and it's very complicated. When you have option 1, option 2, option 3, option 4, it makes it very, very complicated. However, what basically means is that when you have flucytosine, flucytosine is a drug that shortens your regimen. So in the absence of flucytosine, you have to do 14 days. And that's why these last 2, option 4 and 5, are really 14 days of amphotericin B, either liposomal and or deoxycholate. But the first regimen, which is the preferred, has flucytosine. The second regimen, again, is what is called the ACTA. So the first regimen is from the Ambition trial. The second regimen is from the ACTA trial. And then the last, option 3, again, is also from the ACTA trial. But it's the flucytosine that shortens the regimens. And these are the interim options until we have the preferred regimen that will be available. And the reason why we did this, it wasn't clear whether the flucytosine will come before or the liposomal will come before. So we've provided that safety net that if you have flucytosine, you can actually use different options even when you don't have the liposomal amphotericin B. So this is liposomal amphotericin B. It's an antifungal agent, and basically it contains 50 milligrams of amphotericin B, almost like the deoxycholate. But the difference is that when you're giving it, you give a higher dose, either 3 to 4 milligrams if you don't have the flucytosine. If you have the flucytosine, then you can give the 10 milligrams per kg of body weight. But you have to reconstitute it, and then you have to filter it and then dilute. You give in the same fluid, you give in 5% dextrose, 1 liter of 5% dextrose. So when you reconstitute, you use 12 mils of water for injection for each vial, and a patient may need, a 60 kg patient will need 12 vials. So it means you have to reconstitute each of those and then withdraw, filter, and then dilute and be able to administer. And you're able to give in this dose. So this is just a dosing chart that is available, and we can see for the 60 kg person, they need 12 vials, which comes to 150 mils of reconstituted amphotericin B, which now you have to withdraw that volume for the 5% dextrose so that you can be able to dilute and be able to infuse. So some of you are thinking 12 vials is a lot. It sounds a lot and very, very expensive. So when you look at, when you don't have flucytosine, the amount of liposomal amphotericin B you have to give for 14 days, you'd use 56 vials for that 60 kg person over 14 days. But if you're using this single high dose on day 1 with fluconazole flucytosine, you're actually giving less. So that 56 vials can treat so many more patients using the single high dose regimen, which has been shown to be effective and safe. Flucytosine is a game changer. It's an antisynthetic antimycotic agent for induction. It's available in tablets, 250 and 500 milligrams. And the induction dose is 100 milligrams per kg per day in 4 divided doses. You have to be cautious about potential renal impairment and neutropenia. And this slide is just to sensitize you. It's not for you to learn all these things today, because we'll have trainings to really support you to be able to know how to administer. But I just wanted to talk about these molecules that will be available. Some of you in the private sector, you may have been fortunate to be using this. I know some facilities through access programs, like in Homa Bay, have already been using these molecules. But for many of us in the public system, we'll actually have the opportunity finally to use them. So again, when you're giving, there's a dosing chart that has already been developed by the global community, and it really provides guidance. So you are able to know how many pills the person is going to take within a given day. So a 60 kg person will take 12 pills, so 3 tablets every 6 hours to give a total of 12 tablets. I haven't included a slide on fluconazole. We have a lot of experience with fluconazole. So coming to almost the last part of my presentation, and I know my time is up, but just indulge me, is really around development of clinical protocols, guidelines, and SOPs and job aids, and this to be used in inpatient and outpatient settings, and then training the healthcare workers to be able to follow the guidelines and actually provide this care. But more importantly, is really linking the outpatient with the inpatient setting. A lot of the times when we say consult CCC, we want the inpatient to bridge that gap, but we are trying to say, can we as physicians learn all that we are required to do, and therefore provide that guidance, so that when you're calling the CCC, you're calling the CCC for specific things. If you want maybe extra dolutegravir in a patient you're treating with anti-TB, you're calling the CCC to provide the extra dolutegravir. If you want the CCC to provide counseling for the patient, you're calling them for a specific role, but not to call CCC to come and prescribe liposomal amphotericin B, not to call CCC to come and prescribe, even if it's amphotericin B deoxycholate, or even to treat pulmonary TB. So we have to bridge that gap. As physicians, as medical officers, we have to stand in the gap and really provide that linkage, because we say these are the sickest patients, they're the patients who are likely to die. And then more importantly, is really to develop and track AHD indicators, including mortalities. And the article that I started off with was actually asking for that. So these are just some of the job aids we have developed, looking at what you need to do for the 14 days of liposomal amphotericin B in terms of preemptive hydration and electrolyte supplementation, and then administration. So we'll develop each of these for each of the 5 regimens that we've already talked about. And then monitoring treatment-related toxicity, as well as even therapeutic lumbar puncture, which is really very important as part of management of patients with cryptococcal meningitis. And these are derived from the 2022 Kenyan ART guidelines, as well as even the cryptococcal meningitis guidelines. And we've also developed these additional guidelines to really help the healthcare workers. Like if you have hypokalemia, what do you do? If you have elevated creatinine, what should you do for that particular patient? If you have severe anemia is one of the under-recognized complications in patients who receive amphotericin B, and we need to be looking out more for it. So when you have anemia, how do you manage the patient? When you have elevated intracranial pressure, what should you do for different levels of intracranial pressure? So we'll actually be having training on how to do lumbar punctures. And this is where, even as physicians, we have more experience doing lumbar punctures compared to our colleagues who maybe run the CCCs, in terms of they are looking after patients who are ambulatory and well. So let me stop there. Thank you very much, and I'll be available for questions. Thank you.
Thank you very much, Mary Beth, for that short but very interesting and important topic on advanced HIV disease. Thank you for reminding us that that is what we used to call AIDS those many years ago. And it's wonderful to see that the work that your predecessors, Dr. Mary Wangai, I don't know if she's on the floor. Please stand up. Dr. Mary Wangai started this work way back in 2000 in NASCOP. We really appreciate the work you did, and you can see your progeny are doing even much better than before. So asante sana, we recognize you. We will ask you to take questions, and then we'll answer the questions. We'll take the questions at the end of this session. For now, you'll do the talk. I have the pleasure of introducing our next speaker, Dr. Cheryl Khairama, who is an NIH Fogarty Fellow and an award-winning scientist, recognized for her original gene discovery work in idiopathic pulmonary fibrosis and the relationship between the tuberculosis and dysglycemia. She is multilingual, speaks English, French, Spanish, Mandarin, Swahili. We'll add Swahili to the CV, and is currently in a final year of a doctorate in implementation science. We welcome Dr. Cheryl to talk to us about TB and diabetes. Karibu.
Good morning. It's a dull morning. Good morning. Better. Thank you so much, Rosigu, for that wonderful introduction. One of my co-authors is here today, Dr. Eric Njenga. I'm trying to pull him to the dark side of research. These are my disclosures. This was Barack Obama's inaugural address in his first 100 days in office. Today I say to you, the challenges we face are real. They're serious and they're many. They will not be met easily or in a short span of time. But know this, they will be met. As I reflected on these two diseases, this endemic, the inaugural address came to mind, all the challenges that were ahead. So NTB 2035 is a really ambitious goal that we've got globally, and we're racing against time. And the question is, will this dream be realized? Is it time to think again? Why should we think again? Physicians, as you've walked around the TB HIV mandated care facilities, how many times have you seen them taking vital signs, being concerned about the blood pressure? Are we not more concerned with how many pills the patient actually took, whether they're complying, what's their weight? But other than that, not really. The national guideline in Kenya recommends screening using random blood glucose at baseline, and then only recommends glycated hemoglobin for a person who is already known to have diabetes mellitus. So why should we rethink this endemic? Diabetes triples to quadruples your risk of getting tuberculosis. If we're only going to conduct random blood glucose at baseline and have no other follow-up thereafter at their monthly visits or at end of treatment, and if we're only going to have glycated hemoglobin if we know there's diabetes already. But please remember, in Africa, the underdiagnosis rate for diabetes is 69% compared to the global rate of 37%. And here in Kenya, you can read about this work, I think it's been done by Meme and others, our underdiagnosis rate is 40%. So who are we looking for, actually? Do we know who we're looking for? So we need to rethink it more. We presented this work at the UNESCO meeting last year. Is NTB 2035 a comedy of errors? If you're a Leicester football fan, then I'm expecting you to know this story. It's by Shakespeare, and his home is in Leicester. So examining the neglected risk factor, the WHO has established diabetes as a neglected but important risk factor for tuberculosis, alongside the other risk factors like poverty, smoking, alcoholism, HIV, which of course have received a little more attention than diabetes. It's a comedy of errors because let's look at the relationship between tuberculosis and diabetes and pre-diabetes. People who've got diabetes and pre-diabetes are more likely to transmit to close contacts than people who have normal glycemia. This work has been done by Arriaga and others in a really big consortium in Brazil. You can have a look in your free time. Additionally, from a molecular basis, if we're only going to pursue tuberculosis, are we really giving our patients the short end of the stick? And as physicians, are we not going in a circle? When you examine the molecular relationship between tuberculosis and diabetes, the upstream event that provokes the progression or the vicious cycle is a hyperglycemia-induced free radical production. So what you have is hyperglycemia inducing superoxide radical formation, followed by advanced glycation end products. Advanced glycation end products then go ahead to coat your complement. If complement's not working, then your eradication of Mycobacterium TB will be really poor. The next thing that a lot of sugar can do for you in the setting of tuberculosis is reduce the ratio between your T helper 1 and T helper 2. You want a good balance if you want to fight tuberculosis. So in a normal glycemia situation, you have a good balance, almost a 50-50 balance. So you have, I call it multiples of 8. You have Th1 CD8 response, you have T helper 2 CD4 response. In a setting of a lot of sugar or hyperglycemia, what you have is increased T helper 2 response, while your T helper 1 remains the same. With this poor balance, you don't get to eradicate your Mycobacterium tuberculosis. Lastly, escape or immune evasion by Mycobacterium tuberculosis. It can live comfortably in your macrophages, and hyperglycemia assists it to do just this. So that's why I put up this slide. You can read this later in your free time. There's a paper we published last year, a perspective piece on rethinking the syndemic of tuberculosis and dysglycemia. Dessert before main course. If you don't take away anything else from this talk, the main thing I want you to take away is actually these three. Curative care in the setting of tuberculosis and diabetes is terribly expensive, and diabetes results in poor treatment outcomes like treatment failure, multiple drug-resistant tuberculosis, and all these things cost 10 times the cost. 10 times the cost has a figure, it's $3,200 US dollars. Preventive care, on the other hand, if we took up a minimum care package, would cost us 10 times less, about $300 US dollars. Health data poverty can be solved by us in this room. There's a lot of people who do modeling, external organizations to Africa and external to Kenya, but I'm here to tell you that we can solve our own health data poverty problem. Health data poverty is where interventions do not benefit the population where the studies are being conducted. There's a lot of studies that are conducted. I'm sure you're in these R&D institutions, and you ask yourself what the outcome of these studies were. So if you want to take back this power, then we do need to go back to reclaiming our own health data. So let's take a seat at the policy table to shape the cost of care, because one of the things that influences health-seeking behavior is the cost of care. So the aim of speaking on the relationship between TB and diabetes is that we conducted a health economics study. It was a costing evaluation study on tuberculosis and diabetes from a health system perspective. To the best of our knowledge, this is the first time that a health system perspective costing is being done jointly for tuberculosis, diabetes, and we did include HIV because HIV is a common comorbidity to tuberculosis. This is the TUNDI study, TB, HIV, and dysglycemia study. So previously, patient-based costing, you can either do patient-based costing or health system perspective costing. So patient-based costing has already been done by Oyando and others. For diabetes, I think they came up with a cost of 53,000 Kenya shillings or 75,000 shillings if you have hypertension. And in terms of health system perspective, tuberculosis only has been done by Cairo and others, where they found the bottom-up costing is about 38 USD, and for the poor treatment outcomes like drug-resistant tuberculosis, about $3,200. So our study was in Nairobi County. We used Stata to randomly sample to power the study for our objective. We came up with 42 facilities and excluded 6, 4 due to consenting and 2 due to they're no longer being operated. So we sampled 10 out of 17 sub-counties in Nairobi, indicated with a red spot on the map. We went ahead to do valuation at these, we did measurement of the actual building spaces, looking at how much space is used in tuberculosis versus HIV versus diabetes. As you can imagine, the percentage was quite low, something between 15% to 18% maximum, with a lot of these really being the TB HIV. We also found that only 6 of the 36 facilities had a machine to do HbA1c. For the ones who had HbA1c, some of them were not able to operate it because of the requirement for validation or accreditation. We used an open source software, Honor and Keto, to collect the data. So we collected data on staffing, salaries, usage of laboratory facilities, etc. Our approach was bottom-up, where we costed each individual thing that goes into it. So if it's 5 minutes of the nurse, 10 minutes of the doctor, 5 minutes clinical officer, what's that as a percentage of the cost? We also, for our assumptions, we used the 2022 to 2021-2022 USD rate. If you purchase your Mercedes-Benz today, next week it will be, a little less valuable. So that's what GDP deflation does. It values, the current resources for the current value. For the US dollar rate, we just use whatever was the average between the central bank and the World Bank for the time. So these were our results. You can see that the cost of diabetes is incremental. It increases the cost of care by about 16.5% and about 18% in public and private facilities respectively. So the idea that TB and HIV care is free is not actually correct. And we did something called patient journeys, where we followed patients throughout their journey in the OPD, seeing the doctor, going to the lab. And so our costing is based on real-world evidence, like what the hospital is actually doing, as opposed to guideline-based evidence. What we're proposing for the minimum care package is a guideline-based evidence, where we would like to see foot and podiatric care for diabetes within TB and HIV. We'd like to see ophthalmology care for patients who have afflicted by TB, HIV, and diabetes, or TB and diabetes We don't want patients with tuberculosis to only go home having received, their RHZE pills for the week. We'd like to see comprehensive care. So why are we presenting this study? We've actually tabled this study as a cabinet memo, and we're proposing it for a policy change. We're also proposing a shift in the guideline because if you look at what's in the national TB program, like in terms of diabetes, it's not very comprehensive. And also what's in the diabetes guideline, is not very comprehensive for tuberculosis and HIV. So who can change this narrative of what kind of care we'd like to see? It is the physicians, So let us remove power from people who don't know what patients are going through and don't have the evidence for making decisions. So using this data, the time is nigh. I'm here to challenge KOP and KDSG to really table this. The minimum care package that we're proposing is modeled upon the very guidelines that are just here in Kenya, which I think borrowed from ADA, where you get comprehensive care. But in addition, we're proposing a starter pack for a glucometer, for self blood glucose monitoring at home. And there's already community health promoters, and it's already working in TB and HIV. So all we need to do is incorporate. There's also an existing database, TB for TB. So we don't need to reinvent the wheel. So we just need to incorporate the reporting, but we need to make it like mandatory in the facilities. So that's our presentation. Also, our reporting conforms with the CHEERS framework. That's the Consolidated Health Economics Evaluation Reporting Standards, which is part of transparency for our methods. If anybody would like to know about it, you're free to see us afterwards. And thank you very much. Yeah, we'll take questions at the end. Where's my co-author?
Thank you very much, Ariel, for that excellent presentation, reminding us about the relationship between tuberculosis and diabetes. For those of you who have come in recently, we agreed that we'll have all the questions for the three presenters at the end of the session. Let me take this opportunity to introduce our final presenter this morning. This is Professor Rina Shah in absentia. Professor Rina Shah is an ID expert and currently the chair of the Department of Medicine at Aga Khan University. She's an infectious diseases expert and involved in the care for HIV and many other infectious diseases within the private sector. Many years of experience, excellent physician and teacher mentor. On her behalf, the presentation will be made by Marybeth Maritim, who I will take the pleasure of introducing again. Dr. Maritim is a physician, ID specialist, and currently a senior lecturer in the Department of Clinical Medicine and Therapeutics at University of Nairobi. She teaches and practices there. She supervises both undergraduate and postgraduate students, practices at the Kenyatta National Hospital as well as the Mbagathi County Hospital. She's been involved in HIV care and policy for many years, sits in a number of advisory committees and technical working groups within the Ministry of Health, and our current work is in the rollout of the advanced HIV disease policy and capacity building within the within Kenya. So we have a lot of good experience and knowledge in Marybeth. However, she's going to talk about vaccination in the adult, what the guidelines talk about. Thank you. Karibu, Marybeth.
Good morning once again. I'm very happy to make this presentation on behalf of Prof. Rina, who is away. So I think my disclaimer is that I sit in KENITAG. KENITAG is the Kenya National Immunization Technical Advisory Group. I'm the co-chair. And our mandate within KENITAG is really to advise the Ministry of Health on vaccines. So that's just a disclaimer. I'll be making this talk on KAP and Pfizer adult vaccination guidelines. And this is a process that was conducted by the Technical Task Force. And these were the members of the Technical Task Force. There was representation from the various subspecialties within KAP, all the way from cardiology, neurology, pulmonology, oncology, nephrology, endocrinology, rheumatology, infectious disease, gastro, as well as nephrology. And it was, there were other members that contributed to the development of this document as secondary presenters and sharing their data. Public health, Dr. Jeanette Dawa, epidemiology, Dr. Wangeshi Kagushia, Dr. Anthony Etiang from clinical research, Charles Omondi, rheumatology, Martin Macau, who was a medical writer, and Marcy, who was the administration. I apologize for the first slide. It was so busy, I couldn't read all the names, but these slides will be available and you'll be able to see the members who are part of the task force. So the purpose of this initiative or to develop the adult vaccination guidelines is that the immunization policy guidelines had last been reviewed in 2013, and this process actually started about 2 years ago. So at that time, there was a process that was already reviewing the immunization policy at the national level, which since completed its work last year in 2023, and that policy document is now available and was launched last year. So there was a grant from Pfizer that supported and facilitated KAP as an umbrella body to bring together different physicians to develop this policy or this adult vaccination guidelines, which would eventually be adopted as national guidelines for adult vaccination. As many of you may be aware, the current immunization guidelines and policy documents have a bias towards routine immunization, which is given to the children. KENITAG Pediatric Association has been at the forefront of developing additional guidelines to support pediatric vaccination that are actually implemented between the public sector as well as the private sector. So KAP has now risen to its task and has now developed these guidelines, which should be adopted for both, for use in both private as well as public sector. And also it provided that umbrella where the guidelines can now cut across. In one document, you can actually be able to see guidelines that guide in terms of different patient populations, be they be gastro patients or neurology patients or pulmonology patients. So we have a guideline document that provides that guidance within a single document. The main aim of these guidelines is to guide medical professionals on who needs to be vaccinated, against what pathogen and over what period of time, as well as the dosages and schedules for the different vaccinations. So this document is, has been developed through a consultative process, initially domiciled within KAP, but there's a plan to engage the Ministry of Health on policy level, at the higher level, to see how this can now even be adopted at the level of the Ministry of Health on a policy level, as well as gathering information and data within Kenya and other countries in sub-Saharan African countries that already have documents on adult vaccinations. One example would be the South African vaccination guidelines. So it has been a fairly lengthy process, commencing in meetings that started in April 2022. And we had a final meeting just last month on 22nd of February 2024. So it's been a fairly lengthy process with a lot of input and dedication. We've already seen this slide. It's repeated again, so I'll skip it. So the way the guideline is organized, there's a general outline with the first introductory pages really looking at guidelines for a general adult population with no specific indications or comorbidity, so to speak. And then thereafter, there are special vaccine recommendations by specialty or disease area for patients with specific vaccine needs. So the first page is a journal page that looks at a fairly healthy adult patient, and then now thereafter their comorbidities. So in the general adult population, this is defined as individuals who are 18 years and older and above with none of the special recommendation or comorbidities that require special concern. For any individuals with special conditions, there are now specific areas within the guideline that spell out what those recommendations are. And the special areas are arranged in order as per speciality. So this is the first page, looking at the recommendations for the general adult population without specific underlying condition. And basically there's a legend that describes, so the green text are vaccines that are recommended for that patient group, and you can see the ages. So the ages are indicated on the first row. So from 18 years and above, so 19 to 26, 27 to 45, 45 to 64, 65 years and above. And then on this last column, we have special notes or recommendations. And then the legend for the green stands for the vaccines to give. The gray legend, where it appears a lot, many blanks, is not routinely given. And then we have the, I don't know what color that is, like pink, peach color. It's recommended vaccination for healthy adults with specific circumstances. So when we look at COVID-19 vaccination, for that we've made a guidance in terms of reference to MOH guidelines, which are updated from time to time. In terms of influenza, again, it's recommended for adults 19 years and older, up to 65 years, as a single dose annually. For the inactivated vaccine, and then the live attenuated vaccine, 1 dose annually for a certain patient population up to a certain age, because it's not recommended beyond that specific age, and it's contraindicated in certain patient population, pregnancy, immunocompromised states, including those on long-term corticosteroids, because it's a live attenuated vaccine. We have hepatitis B vaccine, the monovalent vaccine, which is recommended as 3 doses, 4 weeks apart. Then we have pneumococcal vaccine, which is more recommended for the older age group, but we'll make reference to pneumococcal vaccines in almost every specialty guideline for patient indication. But in the general population, recommended for the older adult. So the vaccine that's recommended is an initial dose of pneumococcal conjugate vaccine 13 as a single dose, followed by a booster of the pneumococcal polysaccharide vaccine, which is, has multiple antigens, up to 23 antigens, and the booster dose is given after 1 year, 1 dose after the initial PCV13 dose. For HPV vaccine, again, we've made reference to MOH guidelines for update, because the guidelines are being revised to see if Kenya can move to a single HPV vaccine dose for the children who are vaccinated 10 to 14 years. For recombinant zoster vaccine, again recommended for the older patient, older than 45 years, but 2 doses. Typhoid conjugate vaccine for food handlers, 1 dose with a booster every 3 years, and then cholera vaccine, 2 doses administered 14 days apart, then a booster every 5 years, and this is for food handlers, prisoners, refugee camp, people who live in refugee camps, as well as during outbreaks. And then Tdap, which is tetanus, diphtheria, pertussis vaccine, 1 dose, then booster every 10 years. But importantly, tetanus vaccine should be given as part of wound management, a single dose following a wound to prevent tetanus. And then varicella vaccine, 2 doses if never received vaccine in childhood and has never had varicella. So this is a general adult guideline. Now moving on to the various specialty. So for how the document is actually arranged, there is a narrative with an introduction, justification, and providing additional evidence in a Kenyan context, and then now recommending the vaccine. So from the cardiology standpoint, the vaccines that are recommended are influenza vaccine, which again is making reference to the general population guideline, as well as, which is really the annual inactivated vaccine, an annual influenza vaccine using the inactivated antigen every year. And then again, the pneumococcal vaccine with a 2-dose schedule, PCV13, followed by PPSV23. So again, that recommendation. And basically the evidence is that shows that in patients who have underlying cardiac disease, or in the, when they get influenza or pneumococcal, they are likely to get severe outcomes and poor outcomes, and that's why really the justification for these two vaccines from a cardiology standpoint. When it comes to endocrinology, where you're looking at patients who have diabetes mainly, and Cheryl has presented fairly well on some of them, diabetes and TB co-infection. Again, the recommendations are fairly broad. So for patients with type 1 and type 2 diabetes, the vaccines that are recommended, again, is hepatitis B, influenza, pneumococcal vaccines, HPV vaccine, recombinant zoster vaccine, as well as the zoster vaccines, and the narrative is provided beside the recommendation. When you come to gastroenterology, again, hepatitis B is a major comorbidity, and other conditions, again, that are gastro in origin, puts the patients at different conditions. So for the vaccine recommendation, again, patients on immunosuppressive therapy due to autoimmune liver and bowel disease are recommended to receive the zoster vaccine as per the broad outline that I showed at the beginning. Then patients with chronic liver disease, again, recommended to receive hepatitis B, hepatitis A, pneumococcal vaccine, varicella vaccine, as well as zoster vaccine. And then patients with inflammatory bowel disease to receive hepatitis B, pneumococcal vaccine, as well as varicella vaccine. Patients who fall in the hematology, oncology space, again, have a lot of special consideration because of the underlying immunosuppression. But also for these patients, the timing of the vaccination is very, very important, and therefore there is a little bit more on the narrative in terms of how to sequence the vaccination before chemo or after chemo in patients who are receiving specific therapy like anti-B cell monoclonal antibodies, patients post-hematopoietic stem cell transplant. Again, that guidance is provided. And you can see, I think as per each specialty, the more we are going, the longer the list is getting. But by and large, for this one, the vaccines of note are the COVID vaccines, as per the general recommendation. Again, influenza, again, hepatitis B, pneumococcal, meningococcal, vaccine for patients who have asplenia or taking eculizumab, human papilloma virus vaccine, recommendation as per the general population, recombinant zoster for patients who have post-hematopoietic stem cell transplant and on highly immunosuppressive chemotherapy. Haemophilus influenza vaccine for patients who have asplenia or post-stem cell transplantation. Inactivated polio is what is recommended as opposed to the live polio vaccine. And then varicella would be recommended for household contacts of immunosuppressed patients. And then Tdap, MMR you consider 4 weeks prior to chemo, and then inactivated typhoid vaccine as per the general population. So what basically this list is showing is there are different vaccines that you'll need, and some of them you'd have to time them. For example, for patients who are going to undergo splenectomy, you'd need to give them the vaccination before they undergo the splenectomy to achieve good outcomes. And the same also with the patients who are getting the meningococcal vaccine. You time the vaccine before elective splenectomy. For HIV-infected patients, there's a narrative that is provided mainly around the co-infections that are likely to occur in HIV patients, or diseases that are likely to be exacerbated in the presence of HIV. But there's also a guidance in terms of which vaccines to avoid in patients who have advanced HIV disease, so to speak, with very low CD4 counts, less than 200, or uncontrolled HIV that are not currently on antiretroviral therapy. So mainly the live attenuated vaccines are contraindicated because the patient can actually manifest the disease. Nephrology, again, very detailed guidelines. And the beauty of this document is that when you have a patient in front of you, you can quickly make reference to this and really understand the narrative. And for some of this, especially for pre and post-transplant patients, this should be carried out in consultation with the nephrologist. And that's why the nephrology has a lot of text, and you can actually be able to reach out to them before you recommend the vaccine for the different patient population. Again, for the neurology patient, guidance and narratives, and particularly focusing on immunosuppressive therapies such as prednisolone, cytotoxic drugs, and monoclonal antibodies, but by and large recommending a set of vaccines similar to the other specialties: COVID, influenza, hepatitis B, pneumococcal, meningococcal, HPV, recombinant zoster, as well as typhoid vaccine. This is neurology. Then respiratory conditions, the preamble, and then the recommended vaccines. So COVID-19 vaccines, influenza, pneumococcal, and recombinant zoster vaccines, rheumatology, a narrative that's provided, as well as even the vaccines. And you can see the vaccines are more or less similar across the different patient population, but the fine print is really in terms of which vaccine for which patient and if there are any precautions that need to happen. The same again, guidance provided for patients who are taking certain treatments for their rheumatological conditions, and even the timing of the different vaccines and which vaccines to delay and by how long to delay that vaccines. There's a long list of reference that's provided to support the recommendations. Thank you.
Thank you very much, both speakers, for keeping time. We have a few minutes, I think 7 minutes, for a Q&A session. If you have a question, please raise your hand. The microphone will be brought up to you. Now, just to remind you, the first talk was on AHD, advanced HIV disease. The second presentation was on TB and diabetes, with special focus on the TANDI study. And the third talk, as you've heard, has been on vaccination in the adult, an area that I think many of us have neglected in this country. So wonderful expose for that. Questions?
Yes.
Quick introduction, who you are, where you're from, and then ask your question. Make it brief.
Okay, I have the mic. I'll go ahead. Thanks. My name is Dr. Samia. I practice cardiology. And thanks for the speakers, great presentations, meeting this multi-speciality team to discuss. I travel quite a bit and I get fascinated when I'm asked to do certain vaccinations, which I have conspicuously not seen them on the list appearing here. What is the place of yellow fever, polio, vaccination in terms of the disease burden when the big group here constituted by KAP has not even factored those diseases in the vaccination schedule? Should we actually be getting them? Then my second comment is on the role of physician in treatment of many of these diseases we are discussing. I have a feeling we tend to have a lot of burden in terms of performance of a physician. Every small specialty wants to ask the physician to be specialist in HIV care, specialist in doing a bit of ultrasound, specialist in diabetes, specialist in managing heart failure. Sometimes we are lucky to have nurse lead clinicians who help us in these fields, or clinical officers, and they tend to do this every other day to the extent that they may be even better than the super physician in that county. What is the burden we are putting on the physician when he has to double in all these areas and be the top-notch practitioner in each of these field disease areas?
Thank you, Dr. Samia. Next question, please.
Thank you for excellent presentations. My name is Lois Wagana, physician cardiologist. We've had challenges with availability of zoster vaccination. Is it available now in the country, and how can we generate enough demand for it? Because I think the indications are, as you presented, quite clear.
We can take those two first.
Thank you so much for those questions. I think they are targeted at me. So the first issue is around polio and yellow fever, which are travel-related vaccines. So when you look at certain conditions like yellow fever particularly, it's one of the diseases that's under international health regulations. And basically what this means is that member states have to sort of guide in terms of how to address the management when there's an outbreak, when there's when people are coming to their setting. So yellow fever is endemic in Africa and South America, but it's not found in Asia. But the vector, which is the Aedes mosquito, is available. And that's why when you're traveling to countries put an embargo in terms of when you're going to a country that has the vector but doesn't have the disease, like Tanzania, South Africa, they make it mandatory that if you're coming from a country that's considered as yellow fever, you must provide proof that you're either vaccinated, which means that you're not carrying the yellow fever virus within your body. And when you enter the plane, you'll see them doing, it's called disinsection, basically to get rid of any mosquitoes that may be in the plane as you travel to go to those countries like Thailand. And really, this is because the countries don't want any introduction of yellow fever within their jurisdiction. Certain other countries, like if you're traveling to South America, they won't make it mandatory for you to take the yellow fever. But it's in your best interest to take yellow fever because you can get yellow fever by going to those particular countries. The same applies for polio. Polio is one of the conditions that are being planned for eradication. So there's a global eradication initiative for polio, which really mandates countries to put in place certain measures, surveillance, including environmental surveillance, as well as vaccination of people. And for polio, we have 2 vaccines. We have the oral polio vaccine. We also have the injectable polio vaccine. So depending on where you're going, particularly if you're going to certain countries like India, that were really advancing in terms of their eradication processes, they required that you therefore must take an oral polio vaccine before you travel to their jurisdiction. In Kenya particularly, we've had outbreaks. Most of our outbreaks come from our neighboring country where vaccinations are not really at par, particularly in the Horn of Africa. So in our setting, we have repeated outbreaks, and therefore we face that stigma that we really are considered like a polio country. And when you're traveling to any place, then people say, if you're coming from that country that has a lot of polio, then you must take the vaccine. So I think one of the things we may need to include is a section on travel vaccines, just to make that justification and explain why they need to happen. In terms of the physician and the role of the physician, I didn't get a chance to finish my presentation. But my plea and my urge was that these patients are very, very sick. They come to our hospital. They come, and in that hospital, we are the most trained healthcare workers because we understand a lot of pathophysiology and pathogenesis, and we can be able to save those lives. Our colleagues who run the comprehensive care clinics do a fantastic job, but their efforts and skills are limited to those patients who are stable and ambulatory. And my plea was really, can we embrace that concept of looking after these patients so that we can avert mortality? Because it's not too difficult. We don't say this patient has malaria, call Professor Bart or call the malaria specialist. You actually take care of the patient. In a patient who comes with hypertension, we look after those patients. So it's just asking about HIV. What is it about these patients that we can do to prevent lives? Because our mortality data is shocking. For those of you who do mortality data in your facility, I will not be surprised that HIV-related deaths are actually what is driving our mortality, and we can make a difference. Zoster vaccination, again, is very expensive. And one of the things that's really proposed to be the outcome of this exercise of developing the vaccination guidelines is even to lobby for insurance companies if they can include vaccination as part of their coverage, because it makes a lot of sense. If you keep people healthy, then you don't have to incur bills for the aged population when they come admitted to hospital with community-acquired pneumonia, and then they can even get hospital-acquired pneumonia based on something that you could have prevented. Many insurance companies shy away from providing vaccines because they feel that it's a public good. It should be provided by governments. But we hope that through even these initiatives that are ongoing in the national arena, including even this social health insurance fund, we can advocate for preventive healthcare rather than focusing on curative healthcare. Thank you.
Thank you very much, Dr. Maritim. Will, in the interest of time, please make your question very short, and we'll make our answers very short too.
I'm Dr. H.P. Owor. I practice at the Aga Khan Hospital, Kisumu, and I teach at the Uzema University School of Medicine. This is in relation to the presentation on not HIV, diabetes and TB. The current thinking, the resurgence of TB is because of HIV. That is basically what is on the map. However, diabetes contributes quite significantly to the number of cases of, diabetes contributes significantly to the number of cases of tuberculosis. But if you look at the equation right now as we are talking, if you look at tuberculosis and you look at diabetes, HIV seems to sit somewhere right in the center, because HIV can actually give you diabetes, because we have those who develop insulin resistance when they are treated, those who get drugs that push them towards pancreatic disease and they develop diabetes and things like that. Now, my question is, did we actually look at the control measures in both the diabetes and HIV when they developed tuberculosis, so that we can make a conclusion? Because if one has diabetes, which is controlled, optimized treatment of diabetes, that reduces the risk of them getting tuberculosis. The same with HIV. If they are well controlled with a lower viral load, they are unlikely to get opportunistic infections. Did we look at the HbA1c of the patients who had diabetes and maybe HIV? Did we look at their viral loads before we conclude that baby diabetes contributes more to tuberculosis?
I think the question is, what is the relative contribution of diabetes to the risk for tuberculosis versus HIV to tuberculosis? One more question, please. Let's be brief. We are really short of time.
Yeah, thank you. Dr. Yusuf from Mombasa, Aga Khan Hospital, Institutional Clinic, and BOM Hospital. My question is in relation to, for instance, the HANDY study puts it clearly that the cost in the private sector is almost twice what is in the public sector, and also a number of patients actually end there. But the private sector, simply put, so it does not have, even for instance, CCCs, the referral system proper in question. And so what is there? The guidelines are very good for the public sector, where there are lots of good advances in improving care. What do we have in the private sector? And then a short question is, in this global village on the vaccines, we have 13 and 23. Where do we have 20? Other people in other areas are coming with 20. Thank you.
So let's answer those two first, then we can have our last question we close. Thank you.
Thank you, Doc, for your question. To answer your question on contribution, this is funny, but there's currently more people with tuberculosis and diabetes globally than tuberculosis and HIV. As you know, there's been global efforts for control of HIV compared to diabetes. It's all about the money. You know who funds it. So if we want to change that narrative, let's take our data right now. Just here in Kenya, in the rural population, TB and diabetes is 5%, but TB and pre-diabetes is about 37%. In Nairobi urban areas, TB and diabetes is 10% jointly, while TB and pre-diabetes, in fact, Dr. Maritim was part of that study, is a stalking 25%. Age standardized DM is just 3%. So this is to show that when TB and diabetes are together, the relative contribution is really high. I agree with you completely. The contribution of HIV to cardiometabolic disease cannot be ignored. People with HIV are living longer. It's now the era of undetectable, untransmissible. So they're living longer, they're getting cardiometabolic disease, and this is why in a recent trial just last year, there's a recommendation that people with HIV should get statins. In terms of whether HIV is a contributor when there is the 3 comorbidities, this is still out on the jury. 3 studies in Africa have not been conclusive. There's a study by Mabula in Tanzania, there's a study in Ethiopia, and finally the study done by Owiti here in Kenya did not show a relationship, so the data is conflicting. Finally, in terms of diagnosis, HbA1c will underestimate sugar in HIV. So in fact, we don't know the true burden because we are not routinely doing fasting plasma glucose as a way of detecting. To answer the other question, answer the other question. Sorry, what was the other question? I totally forgot.
Dr. Yosa?
Let's see, the costing.
Oh, the
is-
private sector, I remember. Actually, it's not that the cost is, when we did we did individual costing of lab items, staff salaries, etc. It's just that the public sector don't have some of the facilities. So, because we costed real world evidence, what are you doing here? What do you have? This is what we have. That's what we costed. So it's not that it's cheaper because, you know, it's cheaper in public sector. It's cheaper because we don't have some of the equipment. It's cheaper because they're relying on Linda Mama Fund, which may or may not be paid, even at that time, forget now when there's a shift crisis. So it's just cheaper because we don't have some of the things. And finally, it's because only 6 of the facilities had a HbA1c. Most of the costs were contributed to by the lab. So if we don't have most of the lab equipment, then, you know, the cost automatically goes down. So my challenge today is that we need to, as physicians, lobby for this. And can we come up with a simpler framework for validating the labs that's not the complicated NGSP? We're in, like, let's do something that's for us here. NGSP is American.
Thank you very much.
So
I had one question.
Okay, just a final question, and make it short, please.
Okay, I just want to know if there is a desire or an initiative to develop adult vaccination against tuberculosis alongst the malaria vaccine initiative lines. And I'd also like to suggest that we should do more to screen for tuberculosis in newly diagnosed or poorly controlled diabetes or CKD at a policy level or maybe at guideline level as much as we do for HIV. I'd like to know what the panel thinks about that.
Yes, 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 yes. I'm very excited. Nephrologists, if you're in the house, advanced glycation end products are a contributor to CKD, so in tuberculosis. So yes, and there is an initiative for adult vaccination. There's the Gates MRI project. It's running a really big trial in the country related to tuberculosis. I think the most promising candidate was the M72 by GSK.
So thank you so much. So we'll bring this to a close, and I want to thank our session chair, Professor Sika. So let's give them a big round of applause. And let's stand on the podium for our photo, the 3 of you, the speakers. So we'll quickly shift gears to the next session. I'll have Dr. Rosalind Ngugi take over just to give us our next 2 presenters. Then from there, we'll shift gears to our opening ceremony. The governor of Uasin Gishu is coming to join us. And that's why we want to try and keep time to ensure that we don't lag behind as the governor comes. Thank you so much. So now over to Dr. Rosalind to introduce our 2 next speakers. Thank you so much. So big round of applause once again. Excellent job for all our speakers. Professor Mary Beth Maritim, Dr. Cheryl, and Professor Sika, thank you so much. Thank you.
I smile even as I shut down your slides. But one of the things we always insisted when we were asking you to be speakers is when your time is up, you always ignore the placard. So I'm apologizing in advance. You'll have enough time over tea and lunch to ask the speakers any questions that are burning. So let's quickly change gears and invite nephrologist, a consultant physician, and nephrologist based at MP Shah Hospital. He's also head of department medicine, and he's also, it's been amazing the work you have done in terms of transplant in the MP Shah Hospital. He loves to speak, but I've just warned you in advance about time. Thank you. Welcome, Dr. Hussein Baga. He's going to be telling us about the Afran Consensus Guidelines on CKD and the use of the drugs that you guys stole from us, SGLT2 inhibitors.
Okay, thank you very much. Is this working? It's easy, yeah. Okay, thank you very much. Thank you very much to the Kenya Association of Physicians for inviting me to give this talk. This is a paper that we wrote basically looking at the use of SGLT2 inhibitors in patients with chronic kidney disease. It's a concerted effort by the African Association of Nephrology. I was privileged to be representing Kenya in that preparing these consensus guidelines. So this is my disclaimer slide. The views are always my own. So I'm just going to start off with the definition of chronic kidney disease. So we know that chronic kidney disease is defined as a structural or functional abnormality of the kidneys that has been present for at least 3 months with implications for health. Now, why did that come in with implications for health? Because remember that if you have a 70-year-old and if you key in his data in the CKD-EPI equation to calculate his EGFR, you might get an EGFR of 55. But does it have any implications on health? The answer would be no if it doesn't have any problems. So that's very important to realize. Now, if you look at the kidney function, we best assess it using, where's the pointer? Oh, sorry, it's not working. So we assess our kidney function by our estimated GFR, which you get using your serum creatinine, and anything less than 60, which has been persistent for more than 3 months, is defined as chronic kidney disease. Then you have structural abnormalities, which may be manifest by either pathological abnormalities, that means that when you do a biopsy, you see something abnormal on the kidneys, or markers of kidney damage, and the easiest one to do here is your urine albumin, okay? And based on this, the new KDIGO staging criteria uses your EGFR and your urine albumin creatinine ratio to stage your chronic kidney disease, and I would urge all of you to basically do your urine albumin creatinine ratio for all patients who are at high risk of developing chronic kidney disease, especially patients with type 2 diabetes, okay? CKD is important because it is associated with high healthcare costs. How many of us know what the cost of dialysis is per session here in Kenya? How many nephrologists are here? Oh, good. So only 2 smart people, okay. No, it's the truth, we can't deny it. So the cost of dialysis per patient per year is almost 1 million Kenyan shillings. This does not take care into account the hidden costs of the dialysis access, like a fistula, the permanent catheters that we talk about, the risk of infections, the hospitalizations. It's also associated with poor quality of life. Somebody with end-stage kidney disease has to come to hospital at least twice a week for dialysis. So you can imagine how their quality of life is affected. It is also associated with serious adverse health outcomes, including cardiovascular disease. More than 50% of patients with CKD die of cardiovascular disease. It's also associated with development of kidney failure and increased mortality. CKD is currently ranked as the 10th leading cause of death worldwide, with an estimated prevalence ranging from 10 to 16%. Our prevalence of CKD in Kenya is approximated to be 10%. We have more than 850 million people worldwide having chronic kidney disease, the vast majority of whom are living in low and middle income countries. Remember I talked about estimated GFR and albuminuria. Both are very important. As your estimated GFR goes down, so does your all-cause mortality, and so does your cardiovascular mortality. When your albumin creatinine ratio goes up, your all-cause mortality increases as well as your cardiovascular mortality increases. Okay? This is data from the US. You can see that end-stage kidney disease is very costly. The modalities of renal replacement therapy goes up to the tune of billions of dollars. Okay? Of course, it's not as high as the cost that we have in Kenya, but you can know that it's quite significant in Kenya as well because of our GDP. Now, when somebody is on dialysis, their annual mortality, irrespective of their age, irrespective of their gender, irrespective of their race, is significantly higher across the age groups, okay? So our main aim is to make sure that our patients who have got CKD do not end up on dialysis or requiring renal replacement therapy, because it is very costly and the mortality is very high. When you look at CKD in Africa, Africa unfortunately is witnessing a high and rapidly increasing risk or incidence of cardiometabolic diseases, which are the leading contributors of death due to non-communicable diseases in this region. We have had wonderful talks about HIV, about TB, and how the prevalence is quite high in Africa and in Kenya as well. But now we are also witnessing the non-communicable diseases. We are witnessing a high prevalence of hypertension and diabetes. Apart from that, we also have our endemic infections such as HIV, hepatitis B, hepatitis C, TB, malaria. Our people always run to herbalists to get herbal medicines. And then, of course, there's the aspect of going to the pharmacist, getting the over-the-counter medications like your non-steroidals, which are very nephrotoxic to the kidney, and these are projected to drive the burden of chronic kidney disease in Africa. CKD accounts for 4 million disability-adjusted life years lost annually across the African continent. This is slightly lower than the disability-adjusted life years lost due to diabetes, which is 6.4 million. It is also estimated that by 2030, more than 70% of patients with kidney failure will be living in low-income countries, such as those in sub-Saharan Africa, which is where we reside. So you can imagine now the healthcare burden is going to be more of the non-communicable diseases, including kidney failure. Unfortunately, the true prevalence and disease burden of CKD in Africa remains vastly unknown because of multiple factors. One is that we don't want to collect data, we don't want to report our data. There's no standardization of tests across the different hospitals, across the different countries as well. So that is presenting a major problem when it comes to knowing our true prevalence. And our true prevalence is much higher than what is reported. And there are several challenges that we face when it comes to optimal kidney care for our patients with CKD. Financial feasibility is one of them. Majority of the countries cannot afford to provide universal health care to their citizens. Okay? Up to 2014, we only had 600 patients on dialysis. It's only after the former president insisted that the NHIF basically reimburses for our dialysis, is now that we have more than almost 7,000 patients who are on dialysis. But this is in Kenya. How about the other African countries where it is not reimbursed? Majority of these patients die while waiting for dialysis. Then there's the aspect of the clinical and ethical optimization of dialysis services, the lack of uniform and consistent distribution of kidney services, which are the other significant challenges to kidney failure care in Africa. Now, people have to undergo through these stages before they come here. So it's very important to remember that, yeah? You will have somebody who is normal, okay? And it's important that we screen these patients whenever we get the opportunity. Whenever they come to our clinic, please screen them for CKD risk factors. If they're diabetic, if they're hypertensive, if they have a family history of chronic kidney disease, please screen them. Then there are those patients who come here who already have those risk factors. They're diabetic, they're hypertensive, they're obese, they have a family history. Now what we need to do is to assess them whether they have CKD or not. Sometimes we get patients here, which is more and more here and here. Okay? These are patients who already have kidney damage or who have developed a reduction in your estimated GFR and have developed chronic kidney disease. Okay? So most of the times we get patients here. A lot of times I get patients who come in with kidney failure. Now remember, we lose a lot of opportunity when these patients come for routine checkups or they come for infections to our GPs, to our primary healthcare providers. And this is the place where you can actually pick them up and make sure that they don't reach this stage. Because when they reach kidney failure, it's either dialysis or transplant. When they reach here, the mortality is very, very high. Okay? So we need to prevent CKD, and we need to prevent its progression if somebody has developed CKD. And there are various stages. There's a primary prevention, what we talk about. Then there's a secondary prevention when somebody already has CKD and its risk factors. Then there's a tertiary prevention whereby you want to prevent this patient from progressing onto end-stage kidney disease and requiring renal replacement therapy. Okay? This is a slide that I've shown in several of my talks. This is from the CREDENCE trial. CREDENCE trial was basically looking at canagliflozin in patients with diabetic kidney disease. And what they looked at was, on average, the patient in the CREDENCE trial at the age of 63 had eGFR of 56. When you added a RAS inhibitor for this patient, you basically saved them from dialysis by 10 years. When you added an SGLT2 inhibitor, the canagliflozin, you added an extra 15 years free from end-stage kidney disease and free from dialysis, okay? So when you add a RAS inhibitor together with canagliflozin or any other SGLT2 inhibitor, you are basically protecting your patient from developing end-stage kidney disease by almost 25 years. And this is what we want, isn't it? Okay? So this is where we see a lot of our patients when they come in with CKD, the eGFR is less than 60. So this is now where the question came in, how do we use these medications to our advantage in our patients in Africa? Okay? Now, all of the guidelines are currently recommending SGLT2 inhibitors as your first line. This is from the KDIGO guidelines 2022. For all patients who are diabetic, they recommend an SGLT2 inhibitor as your first line if your EGFR is more than 20. The ADA from 2021 broke down the this thing of heart failure and CKD together to to CKD separately and heart failure separately. And again, they recommend that for the type 2 diabetic patients with CKD, SGLT2 inhibitors are going to be our first line. Okay? In 2021, because of the DAPA CKD trial, which was terminated early, the US FDA actually approved dapagliflozin to be used in patients with CKD with or without diabetes as well. So, a lot of these trials, your DAPA CKD, your EMPA kidney trial, your Credence trial, did not include patients from Africa. They did not include our population. So, there was a lot of controversy as to how we are going to use these drugs, beneficial drugs in our population. So, the African Association of Nephrology came together. It was funded by AstraZeneca. And we came up with a consensus report about how to use the SGLT inhibitors in the treatment paradigm of CKD in Africa. And it was termed as an African Association of Nephrology panel position paper. These were all the various authors from different countries. So this position paper intends to provide an overview of the available region and country-specific prevalence and disease burden of chronic kidney disease, the barriers in the management strategies of chronic kidney disease in the African region, and the current evidence on the role of SGLT2 inhibitors and its applicability in different populations with CKD to ensure the safe implementation in CKD management. So the steering committee was convened in November 2022 to discuss the current unmet needs and challenges in nephrology practice for CKD management in Africa. We had 13 key experts in the field of nephrology from 5 African regions, representing 12 countries. We met and we had several meetings to discuss the prevalence and regional burden of CKD and to identify the gaps in effective screening, diagnosis and management of CKD in Africa. And we looked at the current clinical trial evidence of the SGLT2 inhibitors and its implication in the African region. So we proposed recommendations for the implementation of SGLT2 inhibitors as our first-line nephroprotective agents in an effort to reduce the burden of kidney disease in the region. And the recommendations presented in this paper are an outcome of the open discussion among the experts based on the clinical experience in CKD patient care, supported by the published evidence in cardiorenal outcomes of the SGLT2 inhibitors. So when you look at the overall prevalence of CKD in Africa, we can see that West Africa has the highest prevalence of CKD with an estimated prevalence of almost 20%. The lowest is in North Africa. Here in Eastern Africa, we have a prevalence of almost 14.4%. Our prevalence in Kenya is around 10%. The lowest prevalence was reported from Uganda of around 4.8%, but again, remember that this is an underrepresentation, okay, because of lack of epidemiological data. Now, when you look at the kidney care in Africa, it is not uniform, okay? North Africa has better access to kidney care for their citizens. It is poorer in the other regions like in Central and Western Africa, unfortunately. A lot of countries do not have transplant programs as well across Africa, and this presents major challenges, okay? When we look at the CKD etiology and its risk factors, hypertension was found to be the most common risk factor for development of chronic kidney disease in Africa. We have a prevalence of almost 36% of hypertension in Africa, and the incidence keeps on rising rapidly. Now, unfortunately, patients with hypertension tend to develop chronic kidney disease faster in our African population because of the ApoL1, G1, and G2 risk alleles, which we are unfortunately cursed with. Then we also have the hypertensive disorders of pregnancy, like eclampsia, preeclampsia, which routinely lead to chronic disease if they are not checked or treated early. Type 2 diabetes was found to be the second most common cause of CKD. Currently, we have almost 24 million adults living with diabetes in Africa. It is projected to increase to 33 million by 2030 and to 55 million by 2045. Obesity, yes? All of us are responsible for it, isn't it? We all want to have the good food. We all want to sit. We all want to be driven around. Nobody wants to exercise. How many of us know there's a gym here in this hotel on 8th floor? Okay, I told you 8th floor, so now I won't ask. Yes, so we need to be exercising. We need to show our patients that we are exercising as well, isn't it? I mean, if a patient sees us going into the lift and we tell them to take the stairs, they'll wonder, what's wrong with this guy? Okay? Autosomal dominant polycystic kidney disease in the African population. A study in Ghana showed that it was the 4th most common cause of CKD. We also have glomerular diseases, both primary and secondary. Of course, our communicable diseases, HIV, hepatitis B, and hepatitis C, which you can't run away from. Exposure to nephrotoxins. I don't know how we're going to get rid of NSAIDs from the pharmacies and how we're going to stop the herbal medicines. So what we proposed is that we need to identify the risk factors for CKD, what we talked about, diabetes, hypertension, obesity, family history. You screen these patients who have the risk factors using your EGFR and USCR. If they have CKD, then basically we need to assign them a CKD stage using your EGFR and your urine albumin creatinine ratios. And then we implement these CKD management strategies to slow down the CKD progression and also reduce the risk of cardiovascular complications. If your EGFR goes to less than 30 or your USCR is more than 300, please refer to a nephrologist. I don't agree with this figure of 30 because by the time somebody is coming in with an EGFR of 30, there's no magic that a nephrologist will do. We need to refer to them a bit earlier, okay? If the patient is progressing very rapidly, please refer to a nephrologist. If the patient is having uncontrolled hypertension, refer to the nephrologist or also hypertension specialists. If the patient is having electrolyte imbalances, please refer to the nephrologist, okay? Now, SGLT2 inhibitors. These are a novel group of glucose-lowering drugs. Unfortunately, Rosalind, we have to take over from you guys, yeah? They reduce your HbA1c by 0.7%. I mean, they're not very good in terms of diabetic drugs, okay? They act by inhibiting your sodium glucose cotransporter 2 in the proximal convoluted tubule. And because of that, they have a multitude of metabolic benefits and positive clinical outcomes. They do help to reduce your HbA1c. They help to reduce your blood pressure as well. And they do help in reducing your weight, okay? Now, these trials, the cardiovascular outcome trials, were mandated by the FDA after the Avandia vasoconstriction of your afferent arteriole. They will initially cause a reduction in your EGFR. This is expected, okay? And then subsequently, the EGFR slope levels down. So this is how they are renoprotective. They reduce, they basically increase your loss of glucose in the urine, okay? And this reduces your plasma glucose levels. Inhibit glucose reabsorption, which reduces your body fat mass. It reduces your epicardial fat mass as well, and reduction in your oxidative stress and inflammation. And they help in increasing natriuresis and osmotic diuresis, which helps in reduction of your blood pressures, improves your vascular function, and improves your cardiac energy metabolism as well. And this is a mode of action and its beneficial effects on your estimated GFR. So these are the recommendations that the panel came up with. The indications are, of course, when somebody has congestive cardiac failure, established atherosclerotic cardiovascular disease, chronic kidney disease with or without type 2 diabetes, as an additional therapy with ACE or ARBs at a maximum tolerated dose of your SGLT2 inhibitors. And we recommend that they be prescribed in earlier stages of CKD to improve your clinical outcomes. Please do not use them in patients with type 1 diabetes, because these drugs are known to have harmful effects, especially by causing DKA. I've had 3 patients who ended up in the critical care unit because of DKA secondary to use of SGLT2 inhibitors, and all of these 3 patients were type 1 diabetics. It is not recommended to use these medications in patients with an EGFR of less than 20. This is a humble appeal to all of you. If you have started the medications when the EGFR is more than 20 and then it subsequently reduces to less than 20, you are at liberty to continue these medications. Once when the patient starts on dialysis, please stop these medications. We don't have enough evidence for the use in polycystic kidney disease, in lupus, and vasculitis. Okay? Now, what are the practical considerations? So, because there's no evidence of graded response, we basically recommend just using the dose that was used in the trials. So, artagliflozin of 5 milligrams, EMPA of 10, DAPA of 10 milligrams, and canagliflozin of 100 milligrams. The DAPA CKD and the EMPA kidney trial have shown us that your SGLT2 inhibitors can be used safely in patients with CKD stages 1 to 4. Your DAPA CKD trial had more than 600 patients who had CKD stage 4, and was found to be type 1 or type 2 diabetes, especially for patients who are more than 30 years of age with the first presentation. Remember, these patients can also have as well. So please consult a diabetologist to assist you. It's very important, okay? No consultation is needed if the patient is only treated with drugs that do not induce hypoglycemia. If the patient is being treated with sulfonylureas or insulins at very high doses, and these drugs that can induce hypoglycemia, and you want to add on an SGLT2 inhibitor, then it's important to work with our diabetologist colleagues so that we can adjust the doses of these drugs. Okay? Remember what I said, that they only reduce your HbA1c by 0.7% if your EGFR is more than 60. As your EGFR falls, their HbA1c lowering efficacy tends to reduce significantly. So they tend to become more of, if your HbA1c is between 7 to 8%, you may need to reduce your dose of your sulfonylureas by 50% and your insulin dose by 10%. And of course, always advise your patients to self-monitor their blood glucose. If your HbA1c is less than 7%, you can stop your sulfonylureas. The sulfonylureas, unfortunately, do not have very many cardiovascular benefits or renoprotective benefits. Okay? So that's why you need to put the patients on medications that will help for adverse events. If they don't have any risk factors, assess the blood pressure, volume status, the HbA1c level. Now, if a patient has hypovolemia, do not initiate until identifying the underlying reasons and treating them. If the patient has euvolemia or hypovolemia, you can start off your SGLT2 inhibitors. We recommend testing in 4 weeks, especially your serum creatinine. If the serum creatinine remains normal, then you continue SGLT2 inhibitors. If it rises by more than 30% from your baseline, then you need to assess if the patient is volume depleted or if the patient has developed acidosis. If the answer is yes, then you need to discontinue SGLT2 inhibitors and rule out DKA. This is very important. Okay? So, in conclusion, Africa has a substantial burden of CKD, which is projected to increase. A concerted effort is needed to develop the effective prevention and mitigation strategies to overcome the high health and economic burdens posed by the chronic kidney disease. And SGLT2 inhibitors have emerged as potent therapeutic agents that have cardiorenal protective effects, and they have been shown to slow down the progression of CKD in patients with albuminuria. However, a lot more research needs to evaluate their safety and efficacy in our African patients. These are the task force members, and I would like to acknowledge Parul Rishi and Dr. Sushma Jayan, who are instrumental in writing this manuscript, which was funded by AstraZeneca. Thank you very much.
Thank you very much, and thanks for trying to keep time. Like I've told you, we're having a bit of a problem with time, so you'll permit me not to allow for any Q&A right now, and we quickly change gears and move on to cardiology, where we'll have 2 brief talks, and the Q&A will be after the opening ceremony. So I urge you all to write your questions down. The distinct pleasure of inviting the president of KCS, consultant physician cardiologist, Dr. Bernard Samia, to take over this session. Welcome, Dr. Ari.
Thank you. Good morning, ladies and gentlemen. Nice to be this great smart speaker. He's given us quite a bit of what we are going to be discussing in cardiology. And we'll adopt you to include you in our discussion at the end of the cardiology discussions. So it's my pleasure.
Discussion on 2 areas. The first is atherosclerotic cardiovascular disease risk assessment or estimation and treatment choices. Various societies have got their guidelines in terms of a classification of hypertension, and it looks like as the years go by, the levels for diagnosis of hypertension are going lower and lower. And we see the ESC, Kenyan and German guidelines are quite similar with regards to the nomenclature and also with regards to the levels of treatment of hypertension. The British guidelines, the NICE guidelines, as well as the International Society of Hypertension are quite similar, and the Americans have their targets. The reason behind this lowering of the levels for the diagnosis of hypertension is increasing evidence on the risk of atherosclerotic cardiovascular disease with increasing blood pressure. The challenge, however, is that blood pressure is a continuum. And when we look at actual cardiovascular disease risk, it's difficult to say, is it 126 or is it 127 that portends a higher risk? So basically what we have is different ranges of blood pressure over which we have evidence that there is a difference in cardiovascular disease risk. For those people who are inclined to looking at trials, some of the trials that have given rise to this data are the SPRINT trial. The SPRINT trial looked at persons above the age of 50 and looked at their overall cardiovascular risk. And this is a trial that was terminated prematurely because within 3 years, there was a definite difference of 25% difference between those with aggressive blood pressure control, that is below 120, and those with what was considered as less intensive, below 130. So blood pressure for many years was looked at as a number. Is it 140? Is it 160? Is it 180? And all of us will get alarmed when the patient before us has a blood pressure of 180, but not so alarmed when the blood pressure is 150. But the problem with hypertension is that the number only gives you an idea, but what is going on beneath the surface is much more important. Cardiovascular risk estimation has become pivotal in the management of hypertension, and we are now encouraged to classify our patients as low, moderate, high, and very high risk, so that it gives us some impetus in the focus and aggression in our management of hypertension. We estimate the 10-year risk and the lifetime risk for our patients to inform how aggressive we should be in our approach. When I started working as a medical officer in 2002, I was posted to the Nyeri, then Nyeri Provincial General Hospital, and at the time I do remember that about 30–40% of our inpatients were admitted with strokes and heart failure. But what was even more interesting was that most of these patients had been on follow-up in our MOPC for quite a number of years. And now we do know that it's possible to reduce that cardiovascular risk significantly. It's possible to ensure that the patients who are on follow-up in our MOPCs, in our private clinics, do not come down with a stroke or do not come down with heart failure as a result of the hypertension that we ourselves have been managing over time. And perhaps these are targets that we need to set for ourselves, for those that head departments, for those that head institutions, so that you have a way to monitor how well the hypertensive management is going, and hence, actually by extension, how well the atherosclerotic cardiovascular risk management is going. We want to focus on primary or secondary prevention of hypertension-mediated organ damage. So our patients who already have got kidney disease, our smart speaker talked about that, those already have got organ damage. How aggressively are we going to approach these patients? Are we going to be satisfied with a blood pressure of 136, which doesn't sound very bad, or are we going to focus more aggressive care and the use of estimated calculators? Now, this fellow is quite good at looking over the horizon, and it's an approach that estimation of cardiovascular disease risk helps us to do as clinicians, so that we're not just looking at the patient as they appear, but we are looking more in the long term. I like this picture when I discuss hypertension, because what appears above the surface is small, but what is going on beneath the surface is much more ominous. And so when we look at these patients, it enables us to focus on that. The Kenyan guidelines, the cardiovascular disease guidelines, recommend for us to use the WHO and International Society of Hypertension predictor charts for what is called the Afro-E region. So the WHO charts have got charts for people from different regions, and we are categorized under the Afro-E region, which generally is a low atherosclerotic cardiovascular risk population. I personally think that the data poverty is what puts us in this category. Perhaps we are much more higher in terms of our cardiovascular risk, but because there's no information, then we really do not know where we lie. The ESC calculators are quite interesting because they classify different nations with regards to the cardiovascular risk. The Scandinavian countries have the lowest atherosclerotic risk, and countries like Ukraine have got the very highest cardiovascular risk, as well as some of the countries in North Africa like Tunisia are classified. Apparently Tunisia is in Europe as far as ESC is concerned. I relied heavily on the ESC guidelines for hypertension, and they do come in highly recommended as a good read for people who are practicing cardiovascular disease management. The American risk calculators are also useful, and they categorize patients into 3 categories. You have the Caucasian population, you have the blacks and Hispanics, and then we also have those that do not fall into any of those 2 categories. So a lot of argument may be made as to whether we can use these calculations for our population, but they give us more information as opposed to detracting. So this is the Afro-E region calculator for atherosclerotic cardiovascular disease risk. And we have 2 calculators. We have one for the population with diabetes, and we have the one for the people without diabetes. If we can get into the habit of actually looking at these calculators and using them to estimate the risk for our patients, we'll be amazed at how much more aggressive we do need to become as we manage our patients. At the top right corner there, we have the ESC cardiovascular risk calculators. These are tools that you can download on your devices. And on this other side, we have the American ASCVD Plus calculator. And these are definitely something that we can borrow a leaf from. I like this chart, and I'm sure many of us have seen it, which looks at the aspect of classification and grading of hypertension. On the top there, we have the grade, and on the columns to the left, to the right there, we have the actual stages, which help us to put the blood pressure into context. And this is not a point that can be over-belabored because it is what really determines the outcome of our management of hypertension. When we do calculate the 10-year risk score using the calculators, if you like, you can download and calculate your own risk, your own atherosclerotic cardiovascular risk, and you put in your parameters. For populations below the age of 50, a low to moderate risk is less than 2.5%. And if you go along that row to the very end, for patients above the age of 70, the same risk category is a calculated risk of less than 7.5%. So age portends its own independent risk on atherosclerotic disease. High cardiovascular risk for under 50 is 2.5 to 7.5, and very high is greater than 7.5%. I'd like to emphasize on this slide on the very high cardiovascular risk for the under 50. In terms of figures, we see it's just about the same as a low to moderate risk for the over 70-year-old. Let us note that the 10-year risk score calculators tend to underestimate the overall cardiovascular risk for the young patient. And this has been displayed even in cardiovascular disease studies, like one that has been done by Chen Yi, who did a meta-analysis and found a very large number needed to treat for the younger patient with hypertension as opposed to the elder patient. However, we know the elder patient has probably been exposed to high blood pressure for many more years and hence already established atherosclerotics. This is an example that we can look at. A 55-year-old gentleman, blood pressure 156/92 millimeters of mercury. He is a non-smoker. HDL, total cholesterol is 5.2, LDL 4.1, HDL 0.7. We all agree that this doesn't look like a very bad patient. This looks like a patient whose issues are not very complicated. However, when we go on to calculate his cardiovascular risk using different calculators, the WHO Afro-E will put him in the low risk, the ESC calculator will put him in the moderate risk, and the American calculator will put him in the high risk category. Now, an important point here is his lifetime risk of atherosclerotic cardiovascular disease is 46%. And that is generally an inordinately unacceptable risk for any disease. That there's 46% chance that this gentleman in his lifetime will develop atherosclerotic cardiovascular disease. The beauty of this is that it is possible to actually lower this cardiovascular disease. So we want to estimate a 10-year lifetime risk for all our hypertensive patients and use that to guide our treatment decisions. So the same BP number is not the same for different patients. An elderly patient with a BP of 150, a younger patient with a BP of 150 may be presenting to us two different diseases. So how do we manage these patients with hypertension? I hate to gloss over this slide, and I'm not doing that because it is unimportant, but because of the constraints of time. We want to advocate for lifestyle measures, salt intake, vegetables and fruits, fatty food reduction, alcohol. Tobacco warrants special mention because smoking increases the risk of cardiovascular disease, coronary artery disease by 30%, and strokes doubles the risk of atherosclerotic cardiovascular disease by stroke. Physical activity, again, that cannot be overemphasized. So what are our thresholds of treatment? We have a threshold of 140 systolic and diastolic of 90, and in those who already have got established CVD of 130 to 139, and in patients we consider to be very high risk who are equivalents of atherosclerotic disease, we want to target a BP of 130 to 139. A special mention of the elderly, above 65 to 80, we want to target a threshold target of 160, and we consider the aspect of frailty. A busy slide that just looks at the flow chart of that. In patients with grade 1 hypertension who have got atherosclerotic cardiovascular disease, we want to initiate treatment immediately, and we do not want to delay because we know that they already have disease. And in those without established cardiovascular disease, then we want to institute other measures. In grade 2 hypertension, regardless of the presence or otherwise, and grade 3 of atherosclerotic disease, you want to initiate drug treatment alongside other forms of treatment. This is a class 1 indication for prompt initiation of BP lowering drugs for patients with grade 2 or 3 hypertension, and in patients with grade 1 hypertension, lifestyle intervention for everybody. I think we have already said this before, and these are class 1 indications for treatment and intervention. What are our treatment targets? Optimal blood pressure treatment target is between 120 to 130. Those who are older in the room, remember the days that we used to talk about treatment for age. So if you are 60 years, then the target would be 160. If you are 80 years, the target would be 180. These have changed. In the elderly, we are a little bit more lenient, especially because of the risk of falls. Although, on the other hand, it's a double-edged sword. The older you are, the more beneficial blood pressure lowering will be for you. There is no benefit of lowering blood pressure below the 120. The first objective of treating should be a target BP of 140 systolic and below, and in the elderly patients, then we are a little bit more lenient. What do we have at our disposal? It's not possible to discuss hypertension without mentioning this study in which our president, Dr. Felix Baraza, and Professor Ogola were some of the study investigators, and it was looking at combined therapies within the African context, and the combination therapies included a calcium channel blocker with AC inhibitor, that is perindopril, or calcium channel blocker with HCTZ, or perindopril with HCTZ. And this study showed a significant difference between the calcium channel blocker backbone therapy and the perindopril backbone therapy. So it is recommended from this study, you can find it on the New England Journal, that for patients of black origin, black Africans of black origin, then a calcium channel blocker should form part of the backbone on the treatment of hypertension. This is borrowed from the ESC in the hypertensive patient who has no complications. What should be our first line? And we are looking at the need to use single pill combination as opposed to using monotherapy. So monotherapy now is only recommended for patients with a high normal blood pressure who already have established CVD. But in patients who have stage 1 onwards of hypertension with or without ACVD, it is recommended that we use single pill combination, that will use an ACE inhibitor or an ARB in the event that one is unable to tolerate the ACE inhibitor, in combination with a calcium channel blocker or diuretic. And now with the evidence from CREOLE, we know that we need to combine the ACE inhibitor with a calcium channel blocker. And if you're not able to tolerate an ACE inhibitor, then an ARB. Step 2, when you're not able to obtain the target BPs in 3 months, then you want to add a triple combination medication, if available, using an ACE inhibitor, calcium channel blocker, and diuretic. And then you can use 2 pills and onwards. In the patient who has got established cardiovascular disease, or in the patient who is of very high cardiovascular disease risk, the CKDs and diabetics, then we want to be a bit more aggressive in our onset. Again, ACE inhibitor with a CCB, and then you may add a loop diuretic where you have challenges with fluid overload. Step 2, we want to increase the combination to a triple drug and then add. I'm going to really move fast through these slides because of the constraints of time. That's the same slide, just magnified. In the patient who has got coronary artery disease, we want to look at the aspect of addition of a beta blocker before the calcium channel blocker. In experience, most of our patients with high blood pressure in the African setting, you will not achieve good blood pressure control, especially grade 2 onwards, without the use of a calcium channel blocker. So that again remains as a pillar in our treatment. The challenge is when you have got a reduced ejection fraction, then you have to be a bit more cautious as you put in your beta blocker and your calcium channel blocker. In atrial fibrillation, then we look at the aspect of the dihydropyridine calcium channel blockers as part of the armamentarium. The challenge here is to ensure that we optimally anticoagulate before we use this treatment. In resistant hypertension, thank you, I'm done. We want to look at now the issues to bring down the BP. So we want to add on whatever else you have at your disposal, spironolactone or eplerenone, alpha blockers, amiloride, hydralazine, and the very much hated methyl dopa. So this is just a chart that puts in the level of recommendation and the class of what we have already said. Most of these are class 1 indications. Renal denervation, carotid baroreceptor stimulation, this is a class 3 B indication that this should not be used except in trials. Thank you very much. I feel I've not done justice to this very broad topic, but I hope that the discussion will be useful to us in our clinical practice.
Thank you, Dr. Wagana, for eloquently covering that topic. It is indeed a very wide topic, and we may not be able to cover it in a short time. So there is a little dysrhythmia in our program. As you notice, we are expecting some guests, and usually during such moments, you clean your table nicely, clear your throat, and ask the dirty children to stay behind. We're expecting some guests. We're expecting the opening ceremony to be on in a short while, and we have the honor of having the governor of the county of Uasin Gishu to grace the occasion. I'm going to ask the KAP management to take over the program here for the opening ceremony. I can't see any of them here. Maybe while we're waiting for that, we can take 1 or 2 questions to Dr. Baga and Dr. Lois' presentation. No? Okay. Sure. Anybody with a question, clarification to Dr. Wagana, Dr. Baga, while we are waiting for our guests to arrive? Hypertension, CKD? Yes, at the back.
Yeah, thank you. This is to Dr. Wagana. I think that was a very well presented topic, but there's something about the targets, both in diabetes and hypertension. We always have treatment targets. Today, even in hypertension, if you look at the SPRINT and the HIVET trials, there is need to know at what point you want to stop bringing down the blood pressure. And that now brings into point the home blood pressure monitoring. This is very, very important, just like self-monitoring of blood glucose. It has been shown that below a certain level of blood pressure, you do not actually achieve any benefit, especially in relation to the ischemic events. We are talking about myocardial infarction, we are talking about strokes. So I think it would be important also to mention, like, although the SPRINT trial had issues, but even the HIVET, they found that actually if you lower the blood pressure below a certain level, you are actually putting the patient in trouble. Thank you.
Okay, should make a comment on targets, especially in specific patient populations, and if we also need to simplify management of hypertension so that you don't have so many figures for so many patient populations.
Thank you very much, Dr. War. I think I rushed through the presentation, but the absolute floor for blood pressure control is 120 systolic. There is no benefit in bringing down pressure below that level. Now, for patients who have established CVD risk and very high-risk patients, we want to bring down the BP to 120 to 130 millimeters of mercury. And there's an exception there for the elderly above the age of 65, where we can allow a little more laxity to 130 to 140. In the patients who are elderly, the target blood pressure should be 130 to 139. So there's a little bit more generous margin with these patients. One of the questions that would beg is, if a patient, say, has been controlled from the age of 50 and is now 67-year-old, has been comfortable with blood pressures between 120 and 130, they are not frail, they are active, and they are asymptomatic, are you going to relax the blood pressure targets? And I think this depends on personal opinion. My opinion would be no, because this is a patient who's been able to tolerate this blood pressure control. One of the other things that has been shown by these trials is that there is no legacy effect. So if you've had achieved good blood pressure control and you relax it, then you go back to the very high cardiovascular risk. So thank you very much for your question. In the very frail elderly patient above the age of 80, then you are targeting a BP 140 to 160. Thank you.
Thank you for that response. So if I look at the door out there, our guests are almost coming in, but we can take one other question or comment from the audience. Yes, Dr. Ali.
I just want to ask, you know, hypertension causes so much problems for everybody, and it's associated with also diabetes and other conditions, major cause of renal failure. Don't you think it's time we started thinking about comprehensive care clinics? Because by the time we get the information to everybody, it will be another century. The way they have the diabetic comprehensive care clinics for hypertension. The hypertension clinics are massive in every hospital. I'm focusing on public hospitals.
I think that's a very good question, and I think Dr. Samia asked earlier, this physician is being pulled in all directions, HIV, diabetes. We are supposed to be champions in all of this. And I think the key behind that is really on task sharing. We have to accept that we have to task share. I don't know whether we can establish a comprehensive hypertensive clinic, comprehensive diabetic clinic, comprehensive by diagnosis clinic, because again, it is the same personnel that is required to be in these centers. But I think we need to task share a lot more so that our MOPCs are not centers for the physician to shine. Really, they are centers of mentorship where we actually use even our nurses to ensure that these treatment targets are reached. And I think, again, this is a topic for another discussion, but what is the role of the physician as a health educator, as the leader of the team, so that you can achieve more through other hands as opposed to your own hands by yourself? I don't know whether that answers your question or raises more questions, but.
Okay, thank you. We recovered from the shock and looks like the guests have not arrived, so we'll move on to the next presentation as we wait for them.
One more question over here.
Okay, very brief so that we spend the next 15 minutes before the guest comes. Professor.
Thank you very much. Two questions to Baga. Number one, what is the role of SGLT2 inhibitors in uric acid metabolism, and what are the implications for practice in this regard? Number 2, what is the minimum package recommended for patients at risk of CKD? Is there a minimum package? To Dr. Lois, do you have any definitions, targets, and approach to hypertension in pregnancy? Thank you.
Okay, thank you very much, Prof. Yeah, so there have been subset analyses or sub-analyses of the studies that have been done which show that the SGLT2 inhibitors actually do tend to have a uricosuric effect. So they do tend to reduce your uric acid. But however, we need to get more trials, RCTs, to show their positive beneficial effects. But there's no harm in putting a patient who has got diabetes or CKD with hyperuricemia on your SGLT2 inhibitors. When you're talking about your package, I assume you're talking about your EGFR or the dosage, I'm not sure. So the EGFR, as I mentioned, it is safe to use your SGLT2 or initiate your SGLT2 inhibitors when your EGFR is more than 20. Okay, the EMPA kidney is the one that showed that an EGFR of up to 20 is safe to initiate your SGLT2 inhibitors. If your EGFR is less than 20, do not initiate the SGLT2 inhibitors. That is what the recommendation and the guidelines are. And if you have initiated your SGLT2 inhibitors when your EGFR is more than 20 and it comes to less than 20, let's say it goes to 18, do not stop your SGLT2 inhibitors. However, if a patient goes on to develop end-stage kidney disease requiring dialysis, then it's a recommendation by the KDIGO guidelines to stop your SGLT2 inhibitors because of a perceived increased risk of DKA. So I hope that answers the questions. Thank you.
Thank you, Professor Oyo, our eminent teacher. Hypertension in pregnancy, the classification remains the same as the other forms of hypertension. In terms of treatment approach, we want to avoid AC inhibitors, ARBs, the RAS blockers, and we also want to avoid the MRAs because of heterogeneity. So a main pillar for treatment of hypertension in pregnancy is beta blockers. If we have access to labetalol, it will be a preferred choice because of the vasodilatory effect. And then you can use other drugs like calcium channel blockers, methyl dopa, and hydralazine.
I will invite Dr. Lagat to introduce the next speaker who will take us through the second talk in the cardiology segment.
Good morning, everyone, and thank you, Dr. Samia. My name is David Lagat. I'm a physician and cardiologist here in Eldoret. Karibuni Eldoret. It is my duty to invite the next speaker, and our next speaker is Dr. Wafula Nalwa, who is a consultant physician from Kisumu with a lot of interest in cardiovascular medicine and diabetes. I think he's one of the partners in the Kisumu Heart Center, and is an active member of this organization and the Kenya Cardiac Society. It's a 15-minute talk. We'll see if we have time for questions or we'll take them to discussion. Karibu Daktari. The topic is primary prevention of cardiovascular disease. Is it fact or fiction?
Good morning, everybody. We'll have a look at primary prevention of cardiovascular disease. Well, cardiovascular disease refers to a group of conditions that affect the heart and the blood vessels. And the main challenge is atherosclerosis. However, we have other components that include DVT, rheumatic heart disease, and many more. Looking at the statistics from the WHO and World Heart Federation, these conditions are leading cause of death globally. And indeed, they contribute to premature deaths significantly, up to 33%. Cardiovascular disease is premised on certain factors. Foundational to development of cardiovascular disease are certain behavioral factors, that include dietary consumption, physical inactivity, tobacco use, and harmful use of alcohol. Over time, you have an accrual of risk that leads to intermediate risk factors that include hypertension, diabetes, dyslipidemia, that ultimately lead to cardiovascular disease. And therefore, universally, it's agreed that interventions to help stem the tide of cardiovascular disease must address issues of lifestyle. Then we must address issues of policy that creates a conducive environment for sustainable lifestyle decisions to stem cardiovascular disease. And for those who develop cardiovascular disease, then you need to have a way of helping them access treatment and technologies that keep them healthy. But wait a minute. A lot of times we say that cardiovascular disease is affected by lifestyle. Looking at these few questions I have posted, how many of us really have a choice how we are going to live in this present age? For instance, who determines how food is produced or distributed? Who determines the content of food? When you go to the supermarket, who determines the content of that food that is packed that you are going to buy? Who determines the price of that food and affordability of the same? In your estate, is there room for you to play, to cycle safely? Is there room for physical activity? Who controls the sale of alcohol and cigarettes, or access to them? And who accords you the opportunity to access technology and medicines? Is any one of you singularly able to determine what they can access in terms of lifestyle choices? It then brings us to the point that when you think about CVD reduction, risk reduction is a possibility, but risk elimination may not be possible because there are factors that we are not in control of, including aging and gender. There's no study that has demonstrated absolute risk reduction or elimination when you talk about cardiovascular risk factors. However, there are activities that we can engage in to be able to deal with that. Families are aggregators of risk. They're aggregators of risk, whether genetic or behavioral. They provide the environment in which decisions around nutrition, physical activity are made. And therefore, it's important to always ensure that parents have power, ability, and the resources to be able to ensure that the right decisions are made. The risk, therefore, for cardiovascular disease must be addressed from childhood, and children thrive in families. When we talk about cardiovascular risk prevention, we must look at it from the top. When you look at this whole scheme, we are considering the top. And therefore, one of the first things that we need to be looking at is the complete control of the risk of the development of cardiovascular risk factors through the behavioral modification. Primary prevention follows primordial prevention. Primordial prevention deals with controlling the factors that make you develop, for instance, hypertension or diabetes. So when you address lifestyle, diet, exercise, you are dealing with primordial prevention. When you deal with a patient who has developed hypertension or diabetes to prevent them from developing a stroke, then you are dealing with primary prevention. This is where we physicians come in and other medical specialists. There are two perspectives to primary prevention. There's a public health approach where we are dealing with communities. We've talked about playing spaces, diet, and the like. But then there's a second one where we, as physicians, deal with the reduction of the risk factors, reducing or preventing intensification of risk factors. For instance, if a patient is overweight, you want to try and help them not to develop diabetes and hypertension. If you have a patient who has both excessive weight, diabetes, hypertension, that is intensification. you want to try and reverse that process. Physicians are key in that. That process is a multi-step process. You must assess, I think Dr. Lois has talked about it, you must assess the risk, you must plan for change, and you must look at it in a long-term manner. It must be team-based. You cannot do it alone as a physician. You must set up your practice in such a manner that the dietitian has space, the clinical officer who has interest in cardiovascular medicine has space. You must look at your physical therapists, your physiotherapists to have space so that they can all contribute to this process. There's a role for therapies for specific factors, diabetes, hypertension, dyslipidemia. I will not go into them, but they all contribute to prevention of stroke, of ischemic heart disease. So diet is important, high vegetable, fruit, low salt, low sugar. Weight reduction has been shown to be beneficial. 5 to 10% has significant benefit. Cigarette smoking is not debatable. Exercise, we need to look at exercise. You can look at it as moderate intensity, vigorous intensity, and strength training. All of them are different components of exercise, and they are useful. However, there's no clinical trial, for example, in type 2 diabetic patients that has demonstrated reduction. So it means you must continue doing it. You must continue exercising for you to enjoy the benefit on a day-to-day basis. Exercise interventions have demonstrated improvement in CV risk factors, but they do not eliminate them, and it has to be continual. Dyslipidemia, 1 millimeter reduction in LDC is associated with significant reduction, but it doesn't eliminate that risk. It's important, therefore, that you assess, initiate therapy where necessary, empower the patient to make important life decisions every day, and optimize therapy where required. Deal with inertia. Diabetes as well, the UKPDS study showed us that 1% reduction in A1C has significant effects on endpoints in diabetes and cardiovascular disease. There was no threshold of risk of any endpoint. So blood pressure control as well, every 10 millimeter reduction of blood pressure is significantly associated with reduction of cardiovascular risk. Important is you need to ensure that the patient is comfortable. Usual source, they must have a comfortable place they go for care, optimize adherence to treatment, and ensure that you minimize therapeutic inertia. Therapeutic inertia, I don't know how many of you have had patients come to you and they complain that they do not have enough, their BP is not well controlled, but you look at them, they have enalapril 5 milligrams, they have atenolol 25 milligrams. That is suboptimal treatment. They are not on a calcium channel blocker, and that's part of inertia in managing hypertension. In summary, primary prevention is a public health issue. However, for you as a physician, you must deal with the issue of prevention of intensification of risk factors. You have the ability, you have the resources, intellectual and otherwise, to be able to assess and to be able to initiate change. From the Framingham studies, it showed that major risk factors for CVT are additive in predictive power. What that means is that if you have several risk factors and you're able to address each one of them and control and mitigate the effect of those risk factors, the benefit is additive. It therefore means that if you have a patient who has diabetes, treat them to target. If you have a patient who has high blood pressure, treat it to target. If they are sedentary, encourage them to get active. And that's the way you'll get cumulative benefit. Thank you.
Thank you so much, Dr. Nalwa. Very important topic primary prevention for cardiovascular disease and looking at the individual holistically. I know we treat our patients in silos. The endocrinologists would like to do their part, the cardiologists, the nephrologists, but a good way to approach this. So we could take a few questions and comments as we wait for our guests to come in. Any comments, question to Dr. Nalo's presentation, or if it may touch on any of the other? So, Dr. Hari, I think you have spoken quite a bit. Who has not spoken? Yeah, let's start there. Then we'll get back to the mic, please. Somebody to send mic behind there.
Thank you.
Introduce yourself and make your question brief, and I ask also the speakers, please, your responses should be brief.
Okay, thank you for the opportunity. I'm Dr. Sharif. I'm a physician at Wajir County Referral Hospital. And my question is on SGLT2 inhibitors, maybe to the smart physician or the very able cardiologist. So if you have a patient who has, let's say is on dialysis, but also has heart failure and preserved ejection fraction, do we start the SGLT2 inhibitor because they need it and for the cardiovascular benefit, or do we avoid it because of the risk of ketoacidosis? Thank you.
So the smart physician is itching to answer there, but since the question also, the cardiologist may be answering this, I would probably, so you have a patient who has heart failure. SGLT2 inhibitors are indicated across the spectrum of ejection fraction. So your patient probably qualifies as part of the fantastic to have an SGLT2 inhibitor for treatment for heart failure. The only caution the smart physician told you is to look at the EGFR. If you want to initiate treatment, an EGFR of less than 20 would not be ideal. If the patient was already taking it and they deteriorated the EGFR, you could still continue that. Same thing to look at the other medicines. There are always cautions. If you want to do an MRA, you're going to look at the potassium levels. If you want to do beta blocker, again, look at if there are any contraindications for beta blockade, and heart rate especially. Patients with bradycardia may not tolerate this very well. For the RAS inhibition, again, the kidney function, EGFR would be key. Smart doctor, is there anything else to add?
Yeah, so I'm quite impressed by your answer, Dr. Sami. I can see we share, I mean, we are neighbors in terms of our clinical practice, so I think it's rubbing off. So if you look at all the trials, if you look at the DAPA heart failure trial, if you look at the Emperor reduced, if you look at the Emperor preserved, the Emperor preserved and the Emperor reduced had an EGFR cutoff of 20. Now, yes, we do not know what happens when you start it off at an EGFR of 15, but there are studies that are coming up. And my recommendation is always, you have a patient in front of you, okay? And if that patient develops any complications, when you start off in the SGLT2 inhibitors at an EGFR of less than 20, and the guidelines recommend not to do it, then of course you'll get a lawyer in front of you who will appear much more smarter, even though he has never stepped in medical school, talking about all these trials. So my recommendation again is, if it's less than 20, be a bit more cautious, okay? But always have the patient in front of you and individualize each patient. That's what I would say.
Thank you. We will, since we have, yes, our senior colleagues here, please make it brief, just the 2 comments, then looks like we will need to move on to the next presentation. I want you guys who make programs, you know where to slot these opening ceremonies. You should copy from us, be putting the muko mwisho ya siku, otherwise you really get messed up, you don't know what to do. Anyway, go ahead, Dr.
I'm Dr. Gitambo, nephrologist. For the cardiologist, as we go more and more into these non-communicable diseases, have you done anything, or do you not think that it is time to have an input into our CBC curriculum? Because during the last curriculum, physical exercise was removed, obesity was a fashion. It is, and what we eat nobody teaches people what is this, a diet that you don't want us to eat. What should we eat? Just asking whether you have such plans.
Thank you, Daktari. I think we are now venturing into the aspect of policy, but your points are very pertinent. Most of us did not know about high blood pressure or diabetes until we stepped into the medical school. And our contemporaries are now stepping into the age where they are prone to these cardiovascular diseases. So I think education needs to start from primary school, teaching the children on these diseases and the importance of ensuring that treatment is continuous. And then advocacy from a policy perspective. How much salt is in our food? The crisps that we buy to entertain our families, what is the percentage of salt in some of those things? The additives to the food, what do they contain? And those are small, low-lying fruits that we can advocate for. And I think the president of KCS may be better placed than myself to talk about this, as well as the president of KAP. But we do have a key role in the public health aspect of ensuring that we primordial prevent cardiovascular disease.
Thank you.
Yeah, I tend to agree that many of the efforts we've done as societies are mainly geared to practitioners. We've not ventured a lot into the general population, but it's I think, call for action so that our activities go beyond the medical fraternity. We tend to do sometimes public health talks in schools, but the bigger question I think you're asking going into the curriculum, CBC and so on, would have a really great impact. I would say we don't have answers for that, but it's something we should all be thinking about and see how we can help the society at large when they're developing programs at the various, whether primary, secondary, or even college level to promote cardiovascular disease. Thank you.
Yes.
So it's quite an, I'm told when you shall be talking and then the door opens there, you will halt it immediately. I know you'll not do that, Professor.
Yes, thank you.
Yes,
thank you
go
very
ahead.
much, Amoyo from Nairobi. What is the role of non-adherence as a contributor to suboptimal blood pressure control? I know we have all these nice guidelines, but do we know the contribution of non-adherence in our setting? Secondly, Dr. Wafula, you have talked about therapeutic inertia. What is it in reality as it pertains to cardiovascular diseases? And how does it contribute to increased cardiovascular morbidity and mortality? Because you brushed over it, but I don't know whether we have understood you.
Thank you very much. I think compliance and adherence is a big issue in chronic illnesses for various reasons. A lot of these conditions are associated with mental health implications. If you have looked at a number of the patients that you have, they have a degree of either anxiety or depression. A lot of these patients have financial challenges affording the drugs that they have. A number of these patients have side effects. I see quite often erectile dysfunction in men, and they tell you, Daktari, I've not taken the medicines for the last 2 weeks because I'm unable to work at home. And so when you look at all these different factors, they drive patients away from medication. We know that less than 50% of all patients who take their medication actually adhere to treatment. So it requires you to be skilled. It requires you to be tactful, to extract the information in an empathetic manner, in an understanding manner. You need to be able to scale down from branded drugs to generic drugs that they can afford. You need to have an open door policy for them to call you when they are in distress so that they don't necessarily have to incur the cost of a repeat consultation. So there's a lot of emotional intelligence that you require as a physician for you to help them to achieve their goals. I have developed a number of visual aids for me to help my patients to understand why they need to take their medication. And I have accepted that I may have to use very cheap medications that may not be cutting edge as many of us do to be able to control. At the bottom of it all, blood pressure must come down. Sugar must be controlled. You may lose out some benefits, but they need to come down. The other question was inertia. I think a lot of the studies that have been done that have led us to use certain medications have had maximum doses of each drug, whether it's enalapril, whether it's losartan, whether it's telmisartan, whatever it is, they are maximum doses. A lot of the people who are managing those patients who are not seated in this room are not aware of how to escalate the dose. They are not aware of how to combine the different medications, and therefore it behoves you as a physician to have your medical officers under your wing. I actually sit with my medical officers for the first 3 months continuously for us to develop an understanding of how to use and combine medications. So we need to try and do that, and I believe we'll have better results. Thank you.
Thanks for that response. Dr. Roslyn tells me our guests are now here, and she would like to take over the session so that we have the opening ceremony. Yes. So we'll request that you be upstanding to honor our chief guest once they get in, and the KAP team is going to take us through the opening ceremony, the program. Thanks.
Allow me to make a comment as we stand about a question that Professor Oyo asked.
And this is a good exercise for you after all, so don't feel bad.
What percentage of hypertensive patients are controlled? The European data shows that about 35% of hypertension is undiagnosed, and about 50% of it is uncontrolled. The Kenyan data from the Ministry of Health shows at least 50% of hypertension in our setting is uncontrolled. So we really are looking at a possible pandemic. And if you look at the global burden of disease estimates for cardiovascular disease, it looks like the burden is shifting. It's reducing in the West, it's increasing in third world countries, in low and middle income countries. So I think your question, Professor, is pertinent. Dr. Lois Achieng in her MMed thesis looked at the percentage of control of hypertension in Kenyatta, and the data was really appalling. So there's a lot of work to do as far as blood pressure control is concerned in our Kenyan population.
And one of the things we've been trying to encourage is leveraging on technology to improve control of cardiovascular risk factors. For example, in the field of hypertension, the use of technology, telemonitoring, patients with smart gadgets can be monitoring their blood pressure. These figures are transmitted to their clinicians. They can be given response, how to increase their pills or reduce, or what action to do without necessarily going to hospital in person. I'm told they were testing to see how you'll stand when the chief guest comes. So may you please be seated. There's a question here. Sincerely apologize for this. There's a question here from...
So my name is Morgan Mushemi. I'm an ex-Akopia 2 resident at KUTRH. Just to give more input on the question that Professor Oyo has asked about cost-related medication and adherence. So it's actually a pertinent question. And studies that have been done locally actually show that cost-related medication and adherence secondary to hypertension and diabetes are as high as 60%. So this was a study that was conducted in Western Kenya by New York University and Ampath. They looked at actually 2,000 patients, and 60% of them had cost-related medication and adherence, and the biggest factor for non-adherence was actually transport costs. So with such figures, I think there's a project we are working on. It's called NCD Mashinani. I'd like to invite, we'll be presenting it on Friday. So whereby we are looking at how to reduce cost-related medication and adherence in rural Kenya. It's a project we've done with my compatriot Teddy, whereby we have been able to reduce drug cost for diabetes and hypertension by 30%. And it's not much. And we are topping that up with follow-up devices, whereby we're using mobile-based applications, whereby we can be able to follow these patients up. And what we've been able to see is that with using paper charts, just paper charts and controlling medication, we have actually reduced the cost-related medical non-adherence by a significant portion, whereby over an 8-week period, we had 95% compliance because of 1, reducing costs, and 2, being able to follow them up with a paper. So we are looking for partners, and we want to make that paper into a phone app, whereby we follow these people up innovatively. Thank you.
Who else is participating in any community projects in terms of healthcare technology, be it in the diabetes field or hypertension or the cardiovascular field as a whole? Telemonitoring, glucose monitoring, and so on. Who is participating in such programs? Yeah, thank you, Dr. Arif. We have a program that is just been initiated at Othaya, telemonitoring for blood pressure control. I think it's just the 2nd week of recruitment, and we'll be looking at how some of these things can work. A few challenges. These patients need to have smartphones. I don't know in the rural folks how many of them have smartphones. Their sons and daughters have smartphones, but they live in the city, so we're not sure how effective this is going to be. But Dr. Nalo has a comment to make.
Yeah, one of the aspects of good outcomes, I think, for cardiovascular disease is dealing with the mental health of those patients. How many of us have ever done a mental health assessment? Whether it's diabetes, hypertension, CVS, CNS, gastro. How many of them are depressed? We have not done. I think, hello, who has? I think it's significant. I have had patients who are well controlled. Sugar is okay, blood pressure is okay, but they just tell you, Daktari, nimechoka na dawa. How many have had that? I think we need to find a way of either collaboration with the mental health people, or we upgrade physicians to have a significant portion dealing with mental health. Thank you.
Thank you all as we welcome our chief guest, and our leadership of KAP is going to take us through the session. Thank you so much, our chief guest, Pana Governor, for agreeing to grace the occasion of this physicians meeting. So I'll hand over the program to the Secretariat of KAP to take us through.
So thank you so much, and we are now truly honored to have the Governor of Uasin Gishu County, His Excellency Jonathan Bii, and We also have the leadership of the Kenya Union of Physicians from our president, Dr. Felix Baraza. We have Dr. J. Alwoch, our patron, Professor Elijah Ogola, and also we have the chief officer, and also Dr. Thuranira, CS, advisor to the CS, Ministry of Health. So I'll now hand over to the chair, North Rift Branch, Dr. Matthew Koech, to take us through the next proceedings and to invite the subsequent speakers. So thank you so much once again. So over to you, Dr. Koech. Thank you.
Yeah, good morning, everyone, and welcome once again on behalf of the physicians of Eldoret and physicians of the North Rift, which is largely people from MTRH, Moi University, Kitale, Baringo, Iten, Nandi, and Kericho. We really welcome you to this conference, and we don't take it for granted that you took your time to come and share with us the knowledge and the experiences around Eldoret. The theme for this conference is harnessing the power of patient-centered care, taking it from promise to practice. And really it's about that ability to tailor the care that we give to the patient right in front of you. Because nowadays there's so many technologies, so many treatments, and so many options. And we want to empower patients to be able to get the best quality care that gives them the best quality of life, not necessarily the most expensive form of healthcare. So without much ado, I would like to welcome the chair of the scientific committee, Dr. Busakala, to take it on from here.
Thank you, Matthew, for those remarks. Our guest of honor and our colleagues and everybody else, I would like to welcome you to Eldoret, and most important, to the 27th Kenya Association of Physicians annual. It's the pinnacle of our continuous medical education processes. Your Excellency, this is not the only time we gather as physicians to learn. We have weekly meetings where there is a lot of learning. We have monthly meetings, we have quarterly meetings, and each specialty has their own routine itinerary of and as much local research as possible. So you will see a lot of focus on people who come here to present, talking about the studies and the work that they are doing wherever they are doing. Employ more physicians, not just in Uasin Gishu, but also through the Council of Governors. Yeah, so that at least every sub-county hospital, not just county, but every sub-county hospital should have a physician. Thank you very much. Welcome, Dr. Baraza.
Thank you very much, Dr. Busahala, for the kind introduction. And good morning, everybody. Chief guests, Excellency Governor of Uasin Gishu, all physicians, other delegates, good morning once more and welcome to this conference. These hours I'll be talking more about them, big supporters that make this event a success. Before I forget that, we have our patron here, Dr. J. Alwoch, who is also creating this event, having been the founder of this association. I think you can keep him, where did these 3 years go? Now that this is the 27th conference, but we know that COVID ate one of the years. I should make some special mention of the AGM. You are all aware that we are having an AGM this afternoon. I would like actually to have this room as full as it is today, because we need now to discuss internal issues with the association and thereafter conduct elections. I'll be told that by some of my colleagues that they don't attend the AGM because they don't want to be elected to be officials of the association. But I can assure you that, and we want the numbers. We have other packages that I do not forget. We have the both trained physicians at home. So physicians are medical officers who have done the first degree of general medicine, and now they want to transition to be specialized to be physicians. So the college system is a regional college within the East and Central Africa region, and the innovation is you train them at home where they're working. And we are lucky that MTRH is one of the centers amongst others. As we speak, I think we have about 7 or so physicians trained at home. And we really want, or we need the support of the counties so that they can be sending these young doctors to train, which is going to be much easier than them going to Nairobi. For those of us who trained earlier without this opportunity, we had to leave our young families to go to Nairobi for 4 or 5 years, and it was very destructive. So this program is a real innovation, it's good. And the good thing is that it is free, there's no tuition. The only thing we need from you is to continue to pay their salaries, and release them to come and learn. And then from there again, they come back to the counties. So we really count on your support now that you are here. And if we get another opportunity through the Council of Governors, you can come and expound more about this innovation and the program so that the entire counties can be able to support this program. Something else that I should say that with the support of my executive committee, we have been able to apply for a very competitive grant from Britain. It's called Tropical Health and Education Trust Fund, which we applied jointly with the Royal College of Physicians of Edinburgh. And this is going now to help in the training of faculty. I should mention this because things change, times have changed, and this special aspect of this grant is that we are going to train physicians on how to conduct exams.
Professor Alwach, Professor Ogola, Representative Paul Wangwe Ongeti, Chief Officer, Preventive and Promotive. It's an honor to be here to grace this occasion. I'll be very brief because of time. Talking about the gaps, the healthcare gaps that we have in a county, our county is committed to do a policy, locum policy, ignoring the budgetary issues, Then, secondly, before I invite His Excellency the Governor, is to pose a question to the physicians and to all the medical fraternity in general. How will AI affect healthcare? So that is something we need to go on thinking about as we go. Just again, recognition to the, I mentioned advisor, it's advisor of health advisor to the president, right? Thank you. He will clarify. Alex Turanira. Also, I'm happy to see my teachers here. I can recognize Dr. Lagat, Dr. Busahala, and so many of my teachers and classmates. Thank you very much. At this point, I'll request us to be upstanding as I invite His Excellency, the Governor of Singishu County, Dr. Jonathan B. Asante sana.
Thank you very much. You can choose to stand or to sit. It's a very democratic space. Personally, allow me to adopt the protocols as established, but special recognition of some names I'm learning now. The father of this association, Dr. Alwach, followed by Dr. Baraza. I'm trying to struggle to know the names. And then Dr. Ogola, of course, you are part of me. And then another hard name, Turanira. That's a chemical name or scientific name. And the rest of the members. Good morning. Chamgay. You just had missing. Chamgay? Yeah, it's not missing, but with one single S. Yani you emphasize. Chamgay, missing. First, I want to say I'm very much honored to be part of this beautiful meeting of scientists. When you're dealing with scientists, I realized I didn't get the excitement I get outside as a politician. And you know, when you clap to politicians, you set the tempo, and the more the tempo is set, the more the points come. But here you are very quiet, and I'm worried whether I'm in the right place or totally wrong place. But hopefully, let me struggle with the new normal, where people are very quiet. First, I want to say a warm welcome, sincere warm welcome to this significant event in our county of champions. Uasin Gishu, we brand ourselves as champions, and don't tell me which kind of champion. We are farmers champions, we have the athletes. Even in the medical world, we are champions. And I want to say, Karibuni Sana. I extend my heartfelt appreciation to the organizers for choosing Uasin Gishu as the venue for this annual gathering. As we look forward to receiving the city status charter in the coming months, I am confident that your next meeting, I say I'm confident, you know, you don't clap, but that's a point to me. That's a major point. This meeting revolves around theme harnessing the power of person-centered care from promise to practice. And I think it's a good one. And beyond being just an event, it presents a unique opportunity to our county and to you also as researchers. Person-centered care begins. Now I have 3 requests. When you make a politician stand, they will always ask you things. Whether you are able to provide or not, just listen, and it's possible. Collaboration is possible. I don't think we have anything like money or cost anywhere, but we can collaborate. You know, us is purely primary care. Anything going beyond, we refer them to you. City, in terms of Nairobi, Dr. Olwach, you have trained so many of these people that most of them are in this town. And we are not lacking consultants. All we need is collaboration with the county government so that we will, where we are headed is we need more updated, some symptoms, some funny things. So I don't know what kind of a disease I am, but none presenting, even don't know, but it's a disease that they know, and they can prescribe some herbs and you get it and you go. But when it comes to your case now, we don't have scientific name, we don't know what it is, but somehow you have to know and diagnose and get proper prescriptions. Finally, last but not least, is that quality healthcare provision is very important. Let us collectively try, because when you all go, what will happen with the rest of us? Akala here, that we have to regulate also, because the speed at which our people are moving out of this country is so alarming. You are not seeing it, we are feeling it in the village, that so-and-so was a nurse, now destined Australia. So-and-so was what, now going to Germany. People are leaving, and you understand, you are leaving as to who now? Let me ask a simple question. Hoping that you all disappear, what will we be doing in the village? Apart from the lineup on death, who will die next? Next? Because we don't have real medics. My thinking is, can we also think along that how best can we improve our welfare as physicians? How best can we engage with the national government and the county governments? That if we need a physician, which you are very few guys, I don't think we have. How many do you have in our country? Yeah. Huh? Physicians. If the region is 50, it's really dangerous, because I think we need more of you. So as we think along this line, let us rethink the idea of leaving our county for brain drain, because soon we might not have people to take care of us. But because poverty is another problem, and if you think you went to school so that you can save your family and your people and siblings, and you think going to America for greener pastures will help, okay, just go. But hoping that you'll leave with us with more of the doctors remaining at home. Here again, we believe in a mindset that we are the champions. When they were debating about our report of being a city, the support we got from leaders and likely quarters, let me call it Azimio, was enormous. That Senator Khalwale, the bullfighter, your neighbor, he comes from Malinya, just after Musingu. Before you go to Musoli, Shipagala, Pushangala, up to a place called Lunza. Eh? You should know your geography, know your people and know your places. Senator Khalwale, when he was supporting the report, he said, Eldoret is the only slum-free town. Then I looked around and I've never even thought of a slum or something in my mind as a governor. I say, how can this man know my town more than me? Let me tell you, if there is a safe place to live and to work, it is Eldoret. Then Senator Kajwang of Homa Bay said in his support that the only city that you can expand to any direction you want in Kenya is Eldoret. Let me come again. How else would you expand Kisumu? Because the next neighbor is the lake. You will come back. How else will you expand Mombasa? Because the ocean will show you the direction. Even Nairobi, our enviable city, Nairobi, it is not going any further unless you follow the road to Mombasa. The next stage is Machakos. You will no longer be Nairobi. So what am I saying in a nutshell? In other words, I'm saying, should you want to settle and to live and to enjoy your life and to invest, it is Eldoret. Makofi kwa lazima. Senator Oburu, Baba, mtoto ndugu ya Baba, and you know now we are pushing Baba so much until the Azimio group of people are also getting scared. Why are you taking our Baba to AU? We might not give you the real answer, but the better for us, the sooner the Baba goes there, the better for us. And he is an enigma, you know that. But now I'm worried about my little brothers, Governor Orengo, Governor Tichilo, Governor Yako. They are not coming out strongly to support Baba to AU for their own reasons. But what I'm saying is Oburu, Senator Oburu said, the future is urban. So most of the young people all over the world, in Kenya, in this country, everywhere, they are migrating to towns for opportunities. And then I see the president's point on affordable housing. I see it is possible that people will be streaming to towns. That tells me you will have more jobs yourself because people will be coming to your offices to consult. So why should you run away from Eldoret? For sure. I'm not you, but my brain tells me if I were you, I should set to retire here. I'm not saying anything. I'm saying, should you want to think about something else, think of Eldoret. And finally, let me say that coming together and staying together and doing many of these things, we are a family. At the end of the day, we are Kenyans, we are a family, we belong to each other. When you are dealing with a case, it is a case, it is not a tribe, it is not a race, it is not a color of something, it is a case that you want to deal with. And in conclusion, I'm very happy to welcome you again to our home county. Most of the professionals that we know in Kenya, most of them, Dr. Oluoch, they live in Eldoret, most of them. Professional athletes, most of them. All the leaders from Western Kenya here are northern part of Rift Valley. Most of them, they live here. I'm not saying anything. governors, senators, MPs, they have homes here. So can we create a town or a city or an area where the best of the best live together? So that if you are the star in Baringo or a star in wherever, just choose other stars. The likes begets the likes. We come and live together here in harmony. And then as your governor, I want to say karibu sana. In conclusion, I hereby declare the 27th annual physicians meeting officially open. Thank you so much. And
let's be upstanding, please.
So you will allow me opening our annual agricultural show in the next 2 minutes, but I'm still here. But God bless you so much. Karibuni sana. Karibu Barasa. Karibu sana.
So big round of applause once again, and we thank you, Dr. Governor Jonathan B. And as a Kenya Association of Physicians, we'd like to give you a gift, and we thank you for welcoming us to this wonderful city of champions, Eldoret. And we'll surely be thinking of relocating here as well and retiring. So from KAP, from our president, from our patron, Dr. J. Aloch, Professor Ogola, and also from the National Executive Committee and Organizing Committee, thank you so much.
Thank you so much. I used to be a very handsome guy, but nowadays, the age. And I used to hear people gossip about me that I have dimples. Do I still have dimples? And in the medical world, dimples are just some deformities. So I think I'm not a person living with disability. Asante sana. Thank you. I'm really honored for this gift. Asante sana.
Thank you.
Another development, my name has become longer than you think. It is His Excellency. There is a doctor there, PhD, Annie. And then you go with the name, and then comma, PhD, comma, EGH. So be informed. Asanteni sana, Mungu awabariki.
So big round of applause. Thank you so much once again.
Sorry for being disorganized. This is how politicians look like. I have Waziri, my CEC education is here. I have CEO for sports, Naomi, she's the other side. And had we planned, I would have brought all my government to be here so that you really feel you are welcome. Asanteni sana, Mungu awabariki.
So let's be upstanding as he exits the room, please. Thank you. And big round of applause once again.
So, good morning once again. Let's have some order, please. I think we had to release the chief guest because of time. As he mentioned, he has to go to officially open the Eldoret Agriculture Show. So we sort of skipped somebody very, very important from the program just to allow that. So at this juncture again, allow me to welcome Dr. Thuranira, who is representing the Ministry of Health. Thank you.
My senior colleagues, I can see some of my classmates here, and colleagues, good morning. So I had a brief presentation, but I also wanted to draw. So I'm told I have 15 minutes. Rosie, how many minutes do I have? Okay, 50. I'll talk for 20, then I'll request we engage in questions. So there's a lot of thank you. So I was told to come and demystify the many theories going out here about SHIF, SHA, and I'll do a very brief presentation. My presentation is themed Afya Nyumbani. I have so many titles, and I take them by God's blessings. I am not the PA to the CS. I am not here representing the CS. We are two presidential advisors on health, Dr. Daniel Mwai and Dr. Thuranira Kaugiria. So my name is Dr. Thuranira Kaugiria, Technical Lead, Health and Standards in the Executive Office of the President. Now, how did we find ourselves here? We were lucky to play our cards right, and we put a bet on William Ruto, and we wrote his manifesto. And when he won, he told us to come and implement what we wrote. So basically, that's how I got my job. It's a political job. Pata potea. So we have 4 key priorities for delivery of healthcare: health commodity security, human resources for health, digitization and health financing. So I have done us just brief to show you the progress of where we are. Then I do a small discussion on SHIF. So on primary healthcare, it was in the manifesto that we were to identify and commission and roll out 100,000 community health promoters. I know we might have our sentiments around them. Long time ago, I used to believe it's poor medicine for poor people. I decided because I cannot fight it, I join it and tailor-make it to work towards how I want it to be, isn't it? So community health promoters, and they started identification of households. They have electronic gadgets. It's a phone that has an electronic community health information system where they come to your household. They collect your data, health data. They keep advising you on follow-up when you're supposed to go to hospital. They have some basic training. Some of us here, I know them, have been part of the development of the curriculum of community health promoters, and it's available online. Then we did assessment of levels of service. I'm sure most of you, there is a team that came from the ministry to assess your facilities. The reason you are doing that is for the empanelment program. So already we know what you can do, what you can offer, so it's for empanelment. So I'll make all this make sense once I start discussing SHI or SHIF. So improvement of level 2, level 3 is an ongoing program, setting up of primary care networks. We want to reorganize health facilities into primary care networks, where a few level 2s, level 3s, both private, public, faith-based, are organized into one primary care network, which is population-based, and there shall be a hub that shall be a level 4. Then the issue of reorganizing donor funding and external funding, and then the new service delivery model. Now, on the electronic community health information system dashboard, we so far have 31 of 47 counties. So community health promoters in 31 counties are active, going to households, registering households, and these are the counties and the number of households. Nairobi are the leading. They have registered over 700 households. A household has an average of 4 to 5, depending on the data that you want to use. So roughly, we have over 2.4 to 3 million households in Nairobi whose data is available in the ICHIS, we call it ICHIS. So 75,000 community health promoters are active, having registered 3.3 million households out of a target of 12.5. This is a controversial slide. So 1.4 million Kenyans have enjoyed the services from them for screening of diabetes, hypertension, and several have been referred. You can see the numbers here. 71,000 mothers have been reached and they have been referred. 27,000 have been found to have some danger signs that require referral to a health facility. Colleagues, we cannot fight CHP program. It is a big program. It is everywhere. We just need to embrace it and tailor-make it to suit us. Now, on organizing primary care networks, we have digitally mapped the 315, but we are fully established 119. The sample one was the one in Bomet County in Bureti, the one the Deputy President launched. And just statistics to show the update of where we are. Essential medicines list from KEMSA, supply. We are now at an order fill rate of 62%. We were at 28%. Most of you have worked in county hospitals. You know the problem was COVID, and there's a lot of issues that came with the supplies. It is rising to 62. We expect it to reach 75% by the end of the year. Now, this is that thing that I was told to talk about. And part of the work that we did before we landed here is we decided we want to reorganize health. And I wanted to use this thing to write. So I'll take the next 5 minutes to just explain what SHIF is. And the first thing is that I'll talk about NHIF. So most of you have interacted with NHIF. You know the good part of it, the bad part of it. And there are several roles that NHIF used to carry out. So NHIF will come and register you. Number one. They will collect your money. Number two. They will tell you the facilities that you need to go to because you're supposed to choose a facility. Number three. Then you'll go to that facility. They will pre-authorize you. Number four. After that, you'll offer services. They will contract facilities. Number five. They will accredit facilities also. 6. NHIF, once you go seek services, they will decide if this is the correct amount of money to pay and if they are paying. Then they will pay. Then they will investigate themselves in case there is fraud. Then they will also pass judgment on themselves. Okay? So have you heard what NHIF does currently? Now, don't you think these complaints we have been having about NHIF was our own making? We are the same people who, let me say a very unpopular thing, We are the same people who jam that system, isn't it? We are the same providers who collaborate with the ICT department to get capitation of civil servants to our facilities. So you have a facility in Nairobi, but you're capitated to civil servants from Northeastern, so they will never come. So your capitation money is yours. Can I hear an amen? Am I walking on dangerous grounds? Am I telling you the truth? Mumeanza kukasirika? Bado sijaanza. Very good. So based on that, we rethought that we need to sort out NHIF. And there has been 3 attempts to fix NHIF. First, it was called National Hospital. An amendment was moved to do National Health. Then whenever a regime comes, people go make noise and we say representative of providers are not there, it is amended. Then you say representative of faith-based organization, we amend the law, we put them. We are not actually fixing the problem. So when analysis was done, we agreed we cannot fix NHIF. The best thing is to switch it off. So on 1st of July 2024, NHIF will be switched off. So we had a whole transition duration to do that. Now, what is the name of the new institution? Who knows it? Very good, some of you have read. Actually, let me ask, how many of you have read the Social Health Insurance Act? Don't be ashamed of yourself to raise your hand. I know Dr. Kalebi has read. 2 people. How many of you have read the regulations? Hi, Manguda. How many of you have read the regulations? 2 people. 3. We are very proud of ourselves. Clap for yourself. Very good. So I'll summarize it in 5 minutes. So the new institution will be called SHA. SHA is Social Health Authority. Okay? You know, we'll be educating people, so let's learn. So under Social Health Authority, it has been established as a semi-autonomous government agency. It is a saga, or what we call a parastatal, with a board and a CEO. So the board representation, we shall have a chairman, the PS of Health, PS National Treasury, Director General, CEC representative, nominees by both the Cabinet Secretary and Council of Governors, of persons with experience in health finance, insurance or accounting or health economics, and then 4 nominees, 1 from Kenya Medical Association. Informal sector, you know we can't forget hustlers. We are a hustler government. Consortium of providers and KOTU. Now we have a board. So first thing, there are no 3 boards, no 3 CEOs. 1 board, 1 CEO. Tuko sawa mpaka hapo? Now you move on. You have established a board. So the next thing is that we have created 3 funds. There will be a primary health care fund, a social health insurance fund, and the ECCI fund. Primary health care fund shall pay for services offered in a level 2 and level 3 facility, both private, public, and faith-based. Are we together up to there? Where shall this money come from? Taxpayers. Shall we add extra taxation on you? We will discuss that one. But this shall be an exchequer allocation. Our estimation shall be 77 billion to purchase the services for those facilities. Once you're seen in primary healthcare facility that is organized in a PCN, primary care network. You remember I talked about primary care networks? You are given a referral. You will be referred to either level 4, level 5, or level 6. Your social health insurance fund kicks in. Your SHIF kicks in. So your NHIF, let me use what we are used to. Your NHIF starts here going up. We are together up to there? In case your NHIF is depleted because you have a chronic illness, oncology patients, diabetics, hypertensives, their complications, there is a fund here called the Emergency Chronic and Critical Illness Fund. The first C is chronic, The second C is critical. So don't say emergency, critical, and chronic. Emergency, Chronic, and Critical Illness Fund. Where shall it be from? The exchequer. Who shall fund it? Your tax money. How much shall it be? In excess of 50 billion. So you have a 77 here, we have a 50 here, and we have what we are targeting to be 148 billion here. That is a financing model. You shall only contribute for 1. You shall enjoy services of 2. What do you need to access this one? We are starting registration probably next week or next week, but one, you just need to register, put your details. Why are we not copying the data from NHIF? It is backup data. That data has so many issues. 4 of the fingerprints are mine. The other fingerprint is for the provider. Amen. Uncomfortable discussion. So we are redoing the registration for members. So there will be self-registration. You will be sent a link to register yourself, and you put your household name. You shall be given a new NHIF number, which shall call a SHA number. It shall be your ID number. So you won't have to cram another number. Remember, we are moving into the digital ID. So your ID number shall be your health number. Maybe we shall add one or 2 numbers. Now, you have this feeding into this, feeding into this. Article 43(2) says that everyone is entitled to emergency medical cover. Highest level of care, including emergency care. What happens to patients when they get an accident, they are rushed to a nearby private hospital? Naeka laini, start running a drip, and they send you to MTRH, isn't it? Because that bill has to be paid. We have created this fund so that there is access to emergency 24-hour stabilization, and that's where the claims shall be done here. So a private provider shall not in any way be denied services because the person cannot pay. So this is an entitlement to every Kenyan. Okay, every person, not Kenyan, because even a foreigner can access it. So it's every person on this land, this is an entitlement. We are working through the mathematics to see the limits of this critical and chronic, because it can easily be depleted, or this other one, so that we apportion. Work in progress. Now, based on that, so I've explained to you all this. There shall be a new empanelment program. So we shall empanel facilities. We shall be issuing new contracts to start 1st of July. And everybody qualifies. If you have a clinic, an outpatient clinic, and you think you can offer primary care services, you can offer primary care and secondary and tertiary services, you'll be given such a contract. There shall be a whole claim system, whereby once you offer the service, you claim and the money is paid. Issue of claim management, that is where the rot is. So there shall be a claim management office within Social Health Authority, but we are outsourcing the verification. So there's a second line of people who will be verifying those claims. So you put in claims, Dr. Busahala, from your clinic. The office in SHA looks at them, but there's a person who has been given this zone to just counter-check these claims and see if they're fraudulent. If you're caught, it's a lifetime ban. The second last thing, there shall be a benefits and tariff development team. So benefits shall continue being upgraded as we continue, as we get more money, as we look at the disease trends. The good thing is that this panel that shall do benefits and tariff shall be based in a university, a research institution, and shall bring in teams, experts in different fields. They shall come up with the next best benefit to be included or what to be reduced, and the tariff to be charged. Finally, dispute resolution. We have a dispute resolution tribunal. Back to NHIF are the judge and the jury. You have a case, you go to them, they decide you are guilty, or because you have some little money, they forgive you. So now, dispute redress as a patient, as a provider. Now, back to my slides, because I have 2 more slides. Thank you. So based on that, the essential benefits package has since been developed. We are on the last, if you look through the regulations, Schedule 3, 4, and 5, the benefits, I know you'll go read. What your entitlements is there. Costing of the benefits package has been done, itemized costing has been done, so it will come with a tariff. So I'll tell you, based on the guidelines that these beautiful people in this room have developed, what is the tariff for treatment of malaria? What is the tariff for treatment of this? What is the tariff? So that one is work being done, a team of actuaries, doctors are all in that sector doing that. Social health insurance, it's supposed to be SHA. Reforms have been done. Onboarding of reforms have been done. Onboarding of facilities, I've told you by 1st of July, we'll issue new contracts. Level 4, 5, 6 improvement to make the public hospitals competitive, and they compete with private. And so it's an ongoing process. Identification of households, that one will continue. Assessment of levels of service for onboarding, I'll talk about that as the last thing. So the milestones, we have 4 acts already in Digital Health Act. I'll start here. There is no policy that guided how health data is handled. What we have is the Health Act and the Data Protection Act. So we have to tailor-make one that governs the digital health, how you handle health data. So this is the act. Primary Care Act is just to talk about the issues of primary care, level 2, level 3, community health promoters, level 1. First, so more money and governors' residents, health money will remain to be health money. Social health insurance, the act is in, the regulations are done, they will be gazetted tomorrow. So you can read the new. So the last thing is quality of care. We wanted 5 acts. So a Quality of Care Act is currently being drafted just to regulate provision of quality care, regulate registration licensing of facilities. This habit of going to register in 10 different regulators is ending with this one. There will be a lot of backlash because we are taking money from different entities. but it's work in progress. So digitization, the Social Health Authority shall be purely digitized. So by March, KEMSA also, we are going to digitization. There will be a health exchange platform that is being done by Safaricom. All the facilities, and I'll repeat, all the facilities will be in a digital platform. I'm sure you have seen what Muranga are doing. Kisumu has started the work. Mombasa is doing it. Embu is doing it. So we are targeting all the 8,000 government facilities. We are going digital. No, that slide is not supposed to be there. This is what I was talking about here when I was drawing it. And that is my last slide. Thank you very much. So I'll take only one question. You ask the question and you provide the answer. How's it? That's okay? Very good. And then I agree. Thank you.
That's very good. You talked about primary healthcare. I remember when I attended the Alma Mater Declaration, which actually constituted the primary healthcare in 1978. The principle was very simple, and it was basically political. That is democracy in health. That is held by the people, for the people, and of the people. And so many acts you are talking about are not likely to improve the primary healthcare. But more important, universal healthcare. You may not remember, but the first two countries to adopt UHC or free medical treatment were Germany and Britain in 1948 after the First World War. At the end of 70 years, they found that there was still a higher disparity of health services between the poor and the rich, despite the act of the so-called universal coverage. But more important, you talk about act of quality, act on quality of care, but there's a process. There's no point putting an act because that will not check the project. Because you know the quality of care depends on three things. First, the cost. Secondly, the skill and knowledge of the medical personnel. And finally, the so-called environment where the healthcare is delivered. That is the hospital quality and equipment. And those things, you cannot put them in an act, but it's a process. But finally, this shaft or whatever it is, you know, we know in third world, the most important things are the social determinants of health, not all these getting access to the hospital. If you take somebody with Mathari or Kibera with cholera, and you take him to Nairobi Hospital, you get perfect treatment with your social health care. But he goes to the back to Kibera, you have done nothing, basically. You've been saying that 30 to 40% of all our social health improvement will be done by improving our social health determinant. That is accommodation. In fact, one of my professors used to tell him that you African, the only way to improve your health for you to stop eating your own shit, because half of it, that's what happens. But you're not stressing on that, you're just stressing on this money and to get people also. So if I was in the position you wanted to advise the higher mortals, I would tell them to clean Kibera, give Kibera people more cleaner water, better sanitation, and all the vaccination, preventive measures. We know from time immemorial that prevention is better than cure. But you guys seem to be stressing on cure because social health insurance is actually for cure. It doesn't cover preventive health. So there's food for thought for you.
Thank you.
Do we allow a few more questions, then you answer together?
Yes, please.
So, Dr. Thuranira, my name is Dr. Wandia. So, first of all, you have made a very excellent presentation on the Social Health Authority. But you are a politician, and everything a politician says must be taken with a pinch of salt. So, for me, I'm going to hit the nail on the head, and we'll deal with the hemorrhage later. So, what I want to ask is, for those people who run level 3 hospitals, the small hospitals in the peripheries, for instance, in the counties. So we have what we call MAKL, so which ensures teachers and police officers. Most doctors, in fact, you don't even need to run to lose weight. Following up MAKL, you lose 3 kg every month. And there are rumors, and you know, rumors sometimes turn out to be true, that MAKL is the biggest subcontracted funder of the new Social Health Authority. So as a person in the executive office of the president, I want you to confirm with us, is MAKL really subcontracted to fund this? Because it means if MAKL is subcontracted to fund the Social Health Insurance Fund, then doctors are in for a weight loss journey. And yeah, sawa.
I feel like I should respond to that one. It's urgent, eh? So thank you. Yes, I am a politician. You know, I've said all the names that come my way, I take them. Sometimes I wake up and find I'm being abused on Real KMPDU and I take it. So everything is mine, bring it. But more importantly, I understand the journey that people have gone through. Medical Administrators Limited Kenya, MAKL, you know the owner, most of you know the owner. He is a medical insurance provider and a claim settlement agent. He's a, how will I call it? He's an, I'm using good words to say broker. Is he a broker, isn't it? That's the word. He's a broker. And he has terms that 30% of the claims have to be rejected. Somebody clap for me because I know. Is it true? They have targets and they are people. Now, number one, MAKL cannot fund this system. The best they can do is bid to be a claim verifier. The best they can do. The best how they fit into this thing. And I'm explaining, and I want you to hold me accountable. The best they can do in this thing is be a claim verifier. Verifier. Remember, outsourced service. Verifier. So internally, there's somebody who will do it. But externally, as a verifier, that's the best they can come close to this thing. So worry not, Dr. Ari. We are not on a weight loss program. We will not allow you to be on one. Thank you. That one was a bit too sensitive for me to handle. Aya, endelea.
Yeah, my name is Dr. Esther Gitambu. I've done a lot of administration at various levels, including hospital. So I want to point out one thing. You all I love this, what you have done. I think it's the way to go. But all well-laid plans of mice and men are bound to go wrong once now and again. And in our case, if you look at the administrative structures of health facilities and health in general, the government, I'm talking about even the private, but I'm talking about the government, it is really lucky. All right, we have, like in government, we have in the counties, we have the hospitals and the administration, right? Those structures, we have management teams, general management. These things are not standardized. You can take me from the ward and make me in charge of a hospital and expect me to manage it with not a single management bone in my body. I think you should also develop some kind of standard for institutional or county health facility management or county health systems management, which should also be regulated, because you will lay out this system. When it gets to the where you want it to be, it will just collapse because of lack of management skills, all right? There is nowhere in Ministry of Health where you have that as a subject. You must manage systems. You must manage hospitals. You're not born with that skill. People must be taught. It must be regulated. It must be monitored so that you have a higher chance of succeeding. So I think that is another thing that I think you should add to this as maybe the next thing. Who is managing these processes that you're setting up? That should be your Achilles heel right now.
Thank you.
Okay, yeah. Okay. Yes, Yes, good. Thank you very much. Mine is a suggestion, especially at the part of claims. Have you considered using doctors to evaluate these claims using an anonymized system? So you anonymize the name and the hospital, and then you randomly choose doctors to verify for you these claims because they know what they are doing. And then the second suggestion is, could you engage maybe a PhD student to do a cost-benefit analysis of shifting from NHIF to all these things and publish it so that we can all read it? I think the reason why most people haven't read these things is that they see it as an exercise in futility. So if that was done in using a scientific process, and then you told us that your new suggestion is actually more cost-effective.
What is we are being told we are forcing people to be members of SHA. We are forcing people to be members of SHA, and if they're not members of SHA, they will not enjoy government services. Somebody clap for me for that thing. It's a very controversial thing, but let me ask you, doctors. So all of you, I know you are blessed, you own cars. So you sit down, you buy a car, you make sure you have a car insurance for it. Then you go ahead, you have a motor vehicle, you have a driving license. So you have insured your car and you have a license. So, and there's an enforcement mechanism, a police officer stops you, parks hapo kando, insurance anaangalia, kama una, looks at your driving license, you can be convicted or you can pay a bribe. Isn't it? That is Kenya. But when it comes to health, we want to draw the line. We want health to be voluntary. We want it to be, I can pay for it, or I won't be sick, I'm not in the sick population. Then somebody becomes sick. I'm sure all of you are in a WhatsApp group where you're contributing money for a relative, a friend, and there's a bill, you call governors, you call CEOs to try waive bills. At the very least, guys, we need to enforce this thing. It needs to be mandatory for everybody in this room to have a health insurance, whatever. We need to introduce even short courses for that. Now, Dr. Busahala, and your suggestion for doctors. In the new structure that is being formed for social health, the mistake, now let me talk to the past. The mistake that was there in NHIF, there was a case management team. There were no qualifications of members of case management. I'm sure you have heard members of parliament saying the head of case management is a geologist. You have heard that story, isn't it? It is the truth. So the people looking at your claims and verification, none of them has medical knowledge. Your quality assurance officers and the NHIF have no medical knowledge. That is the rot that you are in. That's why they call you and ask you, is appendectomy a major procedure or a minor procedure? You are the mercy of the person on the other side, the answer they will give. So now, in the new structure, the case management, the institution, there will be slots dedicated for medical doctors, pharmacists, dentists, just within the institution, to advise on case student to do a cost benefit. There is some work that has been done that is out there. There's work that has been done by Strathmore Business School. There's work that has been done by a group from World Bank. I think Dr. Frank Wafula has published a lot about the issues of NHIF and the transition. We are not reinventing the wheel. There are things we have been told, Cabinet Secretary Cecily Kariuki's time, and there are recommendations why we shut down NHIF.
Ms. Dr. Emma Karare. Thank you for enlightening us a bit. I still would like to hear from you. You have talked about there's work that has been done concerning cost and benefit analysis. A lot of people are wondering, we've been contributing to NHIF. We've not even accessed that money. It's being shut down. Where is the money that NHIF is holding going? Because it has money. I think it even has investments.
Yes.
we are shutting it down. Hiyo pesa inaenda wapi? Ile wameshikilia. They have held many hospitals. They owe a lot. They're being shut. These hospitals have not been paid. Who will clear those debts? My last question for now. You have just said that the people must register afresh and they will register using their digital IDs. I am not too sure we have started, anybody here already has a digital ID. And this is to kick off by 1st of July this year, the new SHA, SHIV, whatever it is.
SHA.
Yeah, it's SHA and it has the various levels. And I'm asking myself, are you saying really the data that NHIF has, all of it is corrupt? That the details NHIF has for me is corrupted, that I need to acquire a digital ID and register afresh? The cost of new registration, and honestly, the taxes, nowadays you lose an ID, to get a replacement, you pay 2,000. Applying to all Kenyans across the board. We know the nation is suffering. People are crying. The pain that you need to apply for a license to plant arrowroots, beans, food, and then you tell me I have to register, and I know that registration will have a cost to it. Okay, those who do not have the smartphones, this digitization process, what are the systems through which they will register? The people in the nation are overwhelmed by the, and taxes are going up every day. People claim the hustlers don't pay tax. When they buy unga, isn't VAT and excise duty? When you transfer an M-Pesa, there is a transaction includes VAT and it has excise duties, what? Lending rates, the loans, those with the loans are just so high. Have we really considered the life of a Kenyan as we are shutting down and having to register people afresh, and we are shutting down an institution owing many centers, imaging centers, public hospitals, and they haven't paid? How are those hospitals going to continue when their debts are still there and the institution that was to pay has been shut down?
Thank you. Thank you. Allow me to respond to that. She has raised several issues that I wanted to talk about, and thank you very much, Emma, for your questions. And I'll start with the issue of providers. So it is true, NHIF owes providers. They owe providers 29 billion shillings. On Tuesday, we had a meeting, and we had to go and present this to the boss of the country and tell him, we are transitioning, but we owe 29 billion shillings. In today's cabinet dispatch will include the plans for payment monies due to providers. And this money, let me tell you, it is government that has not paid its dues. The police ran away. They didn't pay a debt of 3 billion. They went to MKL. Civil servant scheme and the WIBA, which is supposed to be paid by Ministry of Public Service and Performance Delivery and performance, Linda Mama, supposed to come from Treasury, 4 billion. Edwafia paid and they left. So it is government that owes NHIF to pay providers. Is there a plan to pay? Yes, there is a plan to pay. Actually, to the best of my knowledge, we need to pay providers so that they agree empaneling into the next model that we are doing. We received payment this year. There are 3 kinds of claims. There's an old e-claim. Who has an old e-claim here as a provider? Those people in the former system that was shut down, there were debts there. Then there is what has been accrued up to now, and then the transition. So, Daktari, I can assure you there's a lot of work going on there. We cannot transition with people's debts and you want the same providers to be empaneled. You understand? So there is a specific meeting meant to take place next week for only providers with NHIF Social Health Authority to discuss first the empaneling model, 2, the benefits package, 3, the tariff, 4, the payment of the debt. So it is going to happen, I can assure you that. Number 2, the issues of you have paid contributions, you have never accessed it. You know, a long time ago, there are 2 kinds of systems. So there is a national scheme under NHIF that had everyone, that was paying for bed only, and some little other rebates. Then there are 96 other managed schemes. And there is a scheme there for teachers. That other corner has a scheme for security officers. And these managed schemes are the reason, even if you look at it, are the reason we owe 29 billion, but more importantly, they are the things we have said we don't want anymore. They are the loss-making. The loss ratio for managed schemes was 299%. While the national scheme, they even had surplus money. Money would remain at the end of the year. So now, the issues of choosing hospitals is out of the way now. Once you onboarded into this system. You remember the way people had there's a period for choosing hospitals. Now you'll all be competing on quality. So the best person, the power is to the people. So Daktari, if you give good services, people will go and talk very good about you and all of them will come to you. But if you do bad things, we'll go out there and badmouth you and no one will come your way. So it's a competition of what you do. Now the issue of digital ID, maybe I didn't say it correctly. Your national identification card is your social health authority number. So you will not require another digital ID. It is your ID card that shall remain. Registration is just an online thing. It's a link, you put in your details. It's not we are saying that the data from NHIF is corrupted or it's bad. It's the backup data so that you give us up-to-date data, then we look, compare, we merge them. We pull the other data and we merge what we have. Actually, when the link comes, you'll realize most of the places it's pre-filled because it's based on the data that we have from you from NHIF, from eCitizen. So there's some part that is already pre-filled, your name, your age, your year of birth, probably your ID number. There are some places you'll find it's pre-filled. So it's just an essence of updating your data, and it's ongoing registration because they are in excess. No, NHIF currently has 17 million beneficiaries. So we have 33 million Kenyans who are out there. I tend to think registering afresh is a good thing because we have a big population of people who are not there. The issue of the cost of registration, I've told you now, it will be a link for those ones with smartphones. They're already starting. Safaricom is working on a USSD platform for people with Mulika Mwizi. We envision the registration shall be done in several spots. Number 1, we have 56 Huduma centers in this country. Those are very few, isn't it? We have 35 NHIF offices. You know, they are transitioning. Then we have 300,000 M-Pesa agents in this country. There shall be registration points. Schools shall be registration points. Government service stops shall be registration points. So even if you come to MTRH, there is a registration desk there that will be there. Now, maybe it sounded bad by saying switching off. If you read the acts again, assets, liabilities of NHIF transition to Social Health Authority. So at the moment, the President signed and assented to the Social Health Insurance Act of 2023. The NHIF Act remained repealed. So there's nothing like NHIF now, it's Social Health Authority. So they moved with the assets, with the controversial current land, with their controversial buildings. They move with debts owed to the tune of 24 billion. They move with employees with their different salary scales, and they cross over with everyone. But now a new system of cleaning is coming up. That's why I'm telling you the issue of debt, it has crossed over. So your debt, if you are a provider, is currently a property of Social Health Authority. So they shall continue paying. I tend to assume nearly 70-75% of the debts will be paid by 1st of July, others will continue being paid. The last question was the issue. Yes, I've talked about transition. So I think that's my last question. Thank you. There are two last questions there, then we close. Dr. Kalebi. Thank you. Hey,
Yeah,
thank you for saving me.
Turanira, you said this Pata Potea. I really wish you guys well, because this will be make or break for you.
Thank you.
But I really want to support this thing because I think it will make a big difference. What I really wanted to have a comment and a question. The comment is to the doctors here. I mean, I don't deal with physicians that much because I've been on a break. But I think what I've seen is that a lot of doctors, they have not been participating in this process. No public participation. And things have been done on their behalf, and they'll complain later. Now, what has happened, the regulations are a framework, and now it's supposed to be operationalized. I think I know for a fact, for example, the Kenya Association of Clinical Pathologists were also a victim. People are being sent who are not even competent, so to speak, to go and negotiate on the table. I think doctors need to wake up. As these meetings are happening next week and operationalization is happening, doctors should actually get involved so that you don't blame later. You can actually have your voice on the table. For example, during the national validation exercise, there are no doctors. There are nurses, there are physiotherapists. Yes, there are radiologists. I must say there are also doctors. But most other doctors are not represented. So I just have, the question I have for you, on a practical perspective, I know now you guys are going for the rollout, is will the members be able to access level 4 to 6 facilities, and here it includes specialists, directly, or they have to go through the referral network from the level 2 and 3, like what happens in NHS, for example? And coupled with that, will specialists, which most of the, all the people here are specialists, will their private clinics, which are currently registered under KMPDC, will those get empaneled, or will you still have the same problem of it's only hospitals and medical centers that are empaneled and not the individual specialist clinics, so that they, let's say somebody like, Professor Joey can move from Kisumu, go to Mombasa, and still bill NHIF if your members are seeing him wherever he's going. Yeah.
As I close, thank you, Daktari, for that. It is true, doctors are not attending these meetings. Clap for yourselves. It is very true that the decisions are being made on your behalf. It is very true, we have advertised for regulations. I'm proud that there was a memorandum from you people. Clap for yourselves, I'm happy. At least you did something. But doctors are not participating. Kalebi will tell you who are the national validation. It's a public thing, it is open, it has been put everywhere. We are busy doing our work. Decisions will be made on your behalf. Now, to your question, will members be able to access level 4, 5 services? No. The answer is no and yes. Number one, the no is because you have to be referred from your primary care network. Yes, you have to get a referral from your private care network. And the other answer is yes, because you might be an emergency case that, an emergency case can't wait for a level 2, level 3, level 4, so you can access care. But more importantly, there are some level 4s that will be offering primary care services. So you might be staying here, the nearest facility to you is a level 4, but the level 2 and 3 that are supposed to refer you here are very far away. You can seek your primary care services here. Now, issues of empaneling, we are empaneling everyone's facility. a private facility, a private clinic, a faith-based facility, government facility. So all of you, that's why the assessment for levels of service included private clinics. And the last thing I'll say, I'm happy you have not asked about contributions. Thank you very much.
Right, I stand between you and lunch. Thank you, Dr. Thuranira. All protocols observed. Since this was still part of the official opening of the ceremony, I was tasked with giving a vote of thanks, and we really want to thank you for gracing this occasion representing the Ministry of Health, and we thank the Governor in absentia for having officially opened the conference. Part of the reason why, as we were planning for this conference, we invited government is we felt that we sit in our conferences, discuss the issues, but then if, like he has said, we are not involved in public participation in terms of policy making, coming up with the framework, then we're really not making any progress. So this is to inform you, one, I hope you have had the time to hear about the problems we're experiencing as physicians, the fact that we have started a college of physicians just to ensure that we are all inclusive all over the country. So it's good to just whisper in the CS's ear that we need funding for our college. But at the same time, because at the end of the day, SHA is going to be rolled out whether we are with it or not. And at the end of the day, if our clients, our patients are going to be asking us about it, surely you should be knowledgeable about that. He's managed to, he actually wanted 2 hours to have this discussion, but I can see the hunger on your faces. So he's available for questions over lunch, even as we feed you. But others, I really want to thank you all for gracing the opening ceremony, even as we progress. So thank you, Daktari. And as a note, we really want to thank North Rift Branch for hosting us this year for our 27th annual conference. We had nothing but awesome hospitality. And part of the reason why we chose Eldoret is they're a very shy county. They keep quiet, but it's amazing. One, the amount of research that they're doing, especially at MTRH under the umbrella of AMPATH, and the number of physicians. You've heard there are about 50, yet we don't get to hear about the work. So it's also showcasing Uasin Gishu County. And in that instance, they're going to have a medical inspo, I think in June, where you're all invited, where you'll have the hospital owners, manufacturers talking about what is new, and you'll even have a chance to showcase. So in case you want to move to Eldoret or Uasin Gishu County, you're very much welcome. But others, we really want to thank our hosts for having us on board. I have a small gift to give Dr. Thuranira for taking the time and representing CS of Health and being bold enough to come and talk to doctors about a very controversial topic, but very necessary. Thank you very much.
I've shared with her all the necessary documents, including the to-be gazetted regulations. Kindly find time and read them. I'm really begging you. I feel bad that I've worked this hard and you have not read. I'm so disappointed. Yani, I'm so disappointed. But guys, let's participate. I'll tell you the truth. We have political goodwill. We might have our differences in politics and who we support, but we have somebody who listens to us. You hear we are fighting to be given 122 billion to start funds. We have been fighting here to be given money. Now we seem like you are getting it. Let's be actively involved in shaping the destiny of this country. I submit. Thank you.
Thank you very much. Another round of applause for Dr. Thuranira. Right, on to housekeeping issues. I figured because we managed to skip tea because of the opening ceremony, I'm proposing a change of the program. I'm going to allow you to break for lunch now, 12:30 up to 1:30. Please come back by 1:25, and then we'll proceed with the rest of the cardiology session up to 3 o'clock, and then we'll have the breakout session for about 1 hour, and ensure that you have tea for about half an hour, then you come back. Of note, for those who are not here yesterday, The lunch is actually going to be at Farmhouse Restaurant, which is on the 3rd floor. So when you exit, please ensure that you have your name tag for recognition so that you receive a lunch voucher. Turn to the right, take a lift up to the 3rd. This is for our senior physicians. We are in the home of champions. I encourage the younger ones to take the stairs, go down to the base, to the ground floor, and then there are stairs as you come through Eka Hotel up to the 3rd floor, or the other lift on the other side. But kindly remember, we respect each other, so allow the senior physicians to leave first, and then the rest of us can proceed. It's going to be at the Farmhouse Restaurant up to 1:25. Then thereafter, we'll start at 1:30 up to 3 o'clock. And then for the oncology session thereafter will be held here at Rupa Hall, and the other respiratory session will be at Sosian A and B, which is directly opposite the Farmhouse Restaurant, and that goes on till 4 o'clock. You break for a tea break for about 30 minutes, come back at 4:30, we conclude with endocrinology, and then thereafter we go straight to the AGM. So you're all invited. I expect a full house. So for oncology and the research, we'll have our AGM break and then come for our dinner symposium, which is sponsored by GETS. Thank you all so much for your attendance, for your patience, but this promises to be an exciting afternoon. Welcome for lunch.